Over to you, Dr. Neha. Please start.
Right, sir.
And
So,
now you will be the host and you will take over and make other co-host and coordinate.
uh, right, sir. So, let's begin. Good evening, everyone, and a very warm welcome to each one of you joining us from across the country. It is a very, very proud moment for Research Society of Anesthesia to open this platform dedicated to young anesthesiologists from across the country, coming together not just as clinicians but as contributors to research, leadership, and innovation in our field. सितारों से आगे जहां और भी हैं, अभी वक्त के इम्तिहान और भी हैं, तू शाहीन है परवाज है काम तेरा, तेरे सामने आसमां और भी हैं. Dedicated to all our young anesthesiologists. So, from the corridors of ICUs to the silent vigilance of the OTs, we, the anesthesiologists, we've often worked behind the curtain, but today the spotlight is only ours. This is RSACP Youth Conclave 2025, a space of voice, meaning, and purpose. Today is the beginning of a series of youth-led activities, and we are starting strong with vibrant residents from across the country. We have 9 impressive participants, each bringing fresh insight, sharp research, and interesting thoughts shaped by their experiences and deep work. This event is about recognizing the next generation of anesthesia professionals who are not only skilled in practice but are also ready to lead with clarity and purpose. The winner today will have a lot of chance to enter into the next round, and one of you stand a chance to become the National Youth Orator of 2025. And not just that, we'll have winners who will be introduced, who will be having a special invite to the next RSACP Annual National Conference, which will be held in Indore next year. So let's begin with curiosity, support, and the spirit, of course. कुर्सी की पेटी बांध लीजिए और शुरू करते हैं RSACP Youth Conclave 2025. I would now like to invite Dr. Naveen Malhotra, sir, the President RSACP National, for your kind words, sir.
Namaskar and welcome to Research Society of Anesthesiology Youth Conclave 2025. Let the show begin, and it's your show. We are also young, but we are numerically elder than 40. So we'll be sitting silent and observing you, guiding you, and mentoring you. Research Society of Anesthesiology has numerous platforms for you, numerous opportunities for you to showcase your talent in all the fields, whether it is academics, clinics, and research, you name it and you have it. And we always believe in encouraging the talent, rewarding the talent. So it is the first of the series, as Dr. Neha said, and I'm very happy that the Youth Conclave team, led by Dr. Neha Sinha and Dr. Tanveer Singh, and ably supported by Dr. Nitin Chaudhary and Dr. Neha Sharma, and very superb judges, Dr. Parul Jindal, who is unfortunately just crossed 40, so she is in the role of the chairperson. So she is there from Jolly Grant, Dehradun, a superb pediatrician, a superb clinician, and past president of Uttarakhand State chapter and Dehradun City chapter. And she herself has organized a national conference of Yuva ISA. She had lots and lots of experience, and above all, she is a very good clinician and a very good homemaker. God bless you. I have with us, Dr. Thank you, Parul, Dr. Swati Chavda, the joint secretary of Research Society of Anesthesiology, who is working day in and day out for the Research Society of Anesthesiology. She did a superb conference, Research Society of Anesthesiology Clinical Pharmacology Annual National Conference in Jodhpur last year, and it was a wonderful academic feast with lots and lots of contributions to the society also. She is working with us day in and day out. May God bless her with a very bright future, and you keep on serving Research Society of Anesthesiology in different roles in higher roles, in better roles. God bless you, Swati.
Thank you so much, sir.
And
Thank
the
you for your blessing.
third chairperson, who is also unfortunately crossed 40, is Dr. Nishant Sai. He is the national. He is also a National Governing Council member, along with Dr. Parul Jindal of Research Society of Anesthesiology. Loads and loads of experience with us, with him from AIMS. Swati is from AIMS Jodhpur. Nishant is from AIMS Patna. He has got excellent experience of conducting national classes with me over the years, and he was heart and soul of the scientific program of ISACON 2024 Patna. Nishant is an excellent academician, researcher, and clinician. May God bless him with good health and happiness and bright future in the coming years.
Thank you so much, sir.
Thank you, Nishant. And dear friends, I must tell you, I have got you must have listened to 2G, 3G, 4G. But when 2G was started, I had 6G with me. Dr. Vishal Singla is my student, and today I am happy to share with you that he is into his second term as National Secretary of Research Society of Anesthesiology. Because way back in 2013, when 2G was launched in India, I said you are 4G. When 4G he became 6G. Now we are in 5G, but he's 10G. So God bless you, Vishal. Keep on working for Research Society of Anesthesiology with the same spirit and same enthusiasm.
Thank you very much, sir, and regards.
And dear friends, to all of you, we all derive this energy from one person, Professor Tej K. Kaul. I won't tell his numerical age, but he still looks to me 16. And we derive energy, passion, compassion, enthusiasm from him. So I won't stand between you and him. Dr. Tej K. Kaul, sir, I request you to bless the next generation. You have blessed us, and now it's time to bless the next generation. Over to you, Dr. Tej K. Kaul, sir, past President, Research Society of Anesthesiology, past editor, GOCP, and patron, Research Society of Anesthesiology.
Good evening, everybody, particularly the younger generation of the RSACP family. We have the national coordinators and the state coordinators amongst us. And I must tell all the participants in this RSS Youth Enclave 2025 that the dynamic Dr. Naveen and Dr. Vishal have given you a great platform where you have chances to excel and where all your dreams could be fulfilled, provided you work very hard and sincerely. Dr. Naveen and Dr. Vishal, as they said that they were also a few decades back young, less than 40 years. But remember one thing, that they haven't become leaders and top administrators in a day or in a month. They have worked tirelessly and sincerely for decades together to reach this level. And this is a great idea of Dr. Naveen to give a platform to the younger ones so that you also excel. His idea of making the future leaders is absolutely brilliant. This is a great novel idea. And all of you must take the opportunity to not allow this opportunity to go away and work tirelessly hard and sincerely to bring RSA to its top level in the country and make a presence felt at international levels. Before I close, I must remind you of one thing, that is you must develop passion, because when passion fuels purpose, there should be a purpose for this. So when passion fuels purpose, eagerness becomes unstoppable. Be that unstoppable individual to achieve the best in life for the society and for the humanity. God bless you all. Thank you. Thank you very much.
Thank you, Dr. Kaulsar. And I must acknowledge the role of heart and soul of this program, who have been fulfilling my dream to provide a platform to the young anesthesiologists. Very dear Dr. Tanveer Singh and Dr. Neha Sinha. Dr. Neha Sinha is a pain physician and consultant at AS Pain Management Center, and she is the National Governing Council member and the National Youth Coordinator of RSACP Youth Conclave. She is very, very passionate that yes, something should be done for the youth anesthesiologists across the country. And that's why I have given this mantle to her, that you tell us what platform is needed and we will create it. Thank you, Dr. Neha. And we look towards you for giving us more inputs and insights and keep on poking us. Thank you very much.
Thank you, Dr. Tej K. Kaulsar. Thank you, Dr. Naveen Malhotra.
And let me thank Dr. Tanveer also, a meticulous, silent planner who likes to work silently behind the scenes, but he is very, very meticulous. And he's also National Governing Council member of Research Society of Anesthesiology and the National Coordinator of Research Society of Anesthesiology Youth Conclave. A very simple person, down to earth, work alcoholic, teetotaler, and whatever you say to him, it is done. Thank you, Dr. Tanveer, for your all-round support, whether it is logistics, whether it is planning, whether it is execution, and whether it is human relations. I tell you, if you get a chance to meet him, interact with him, he will tell you how to maintain and how to sustain relations. God bless you, Tanveer. Thank you very much.
Thank you, Naveen sir. Thank you, Dr. Paul sir. Thank you, sir. Thank you.
Over to you, Dr. Neha.
Thank you, sir. Thank you, Kaulsar. Thank you, Naveen, sir, for believing in us actually, so that we can bring thoughts and visions to reality. Thank you very much, sir, for that support and for that, the pillar that you have always been. So, moving on, I would now like to invite our very own Dr. Vishal Singla, sir, for a few words, sir.
Very good evening to everyone. My regards to our patron, Dr. Tej K. Kaulsar, President, Research Society of Anesthesiology, Dr. Naveen Malhotra, sir, Vice President, Dr. Anju Garewal, ma'am, all the Governing Council members of Research Society of Anesthesiology, and all the delegates present here. Dr. Neha, मैंने सीट की पेटी बांध ली है, and I am ready for the ride. I am sure it will be the great one.
Absolutely, sir.
And Naveen sir हमेशा कहते हैं कि when 1G was there, I was 2G, then 3G, 4G, 5G, 6G has come. But I would like to tell you, sir, that when 1G was there, we already labeled you as 100G. So we have always been aspiring to achieve the benchmark which you have set, and 100G probably in our lifetime we would never be able to achieve, sir. And this is a simple fact. The benchmarks which you set for all of the society, for all of the young anesthesiologists, and for all the members of the society, those benchmarks we all aspire to, we all strive to aspire to achieve those benchmarks. I would like to thank each and every one of you, all the delegates, for being here with us today. Research Society has always been pioneer in promoting academics. A proud movement for Research Society of Anesthesiology to launch this series of Youth Conclave to give a chance to showcase the series, showcase the work of the youth. Before this, we have been holding webinars, physical activities, workshops to keep abreast with the latest and the everyday topics. And continuing in the same spirit, this Youth Conclave is here to nurture the power of the youth. I would like to thanks and congratulate our national coordinators, Dr. Neha Sinha and Dr. Tanveer Singh to bring in this wonderfully crafted youth conclave. And also I would like to congratulate for you for all the hard work you have done to bring this project a reality. Once again, I would like to thank each and every one of you for being with us here today for this youth conclave. All the best to you, Dr. Tanveer and Dr. Neha. And मैंने पेटी बांध ली है.
Thank you,
very
Dr.
much.
Vishal. And I must acknowledge also Dr. Nitin Chaudhary and Dr. Neha Sharma. Nitin is young Yuva and is an integral part of Youth Conclave. And one thing I can tell you, he has got the maximum number of awards during the RSAP conferences in the different competitive award sessions. He presents every year. He presents 2 to 3 award papers, and most of the time he is the first winner. Keep on doing good work in research, academics, and clinics, and God bless you with good health and happiness always, Nitin. God bless you. So, and I also praise and acknowledge.
Thank you for your kind.
Thank you, Dr. Nitin. The presence of RSAP National Governing Council members from different parts of the country, Dr. Gauri Arora, and our state and city members of the Governing Council, Dr. Vishnu Mesh Babu, and Dr. Ankur Khandelwal, I can see, and other colleagues. So before handing over back to Dr. Neha Sinha, I tell you now, yes, these were only 15 minutes for us. Dr. Kapil Singhal is also there with us. He is a very, very young leader, though more than 40. So he is Dr. Geeta Singaria is there from Jodhpur, and Dr. Lalit is from Udaipur, and I can see Dr. Gurcharan from Panipat. So they are all there with us, participating and eager to listen to you in the youth conclave. I request all the judges to judge all these participants. We have got also Dr. Nirupma Bansal from Faridabad, past president of Frida branch, and to be totally judge them on the merit and also motivate them. It is the beginning of the first session. Over the period of next 1.5 months, we will have different sessions in different categories, and the winner of each session will move on to the next one. And definitely, as per the Research Society of Anesthesiology policy, there are attractive prizes. But for us, all of you are winners who are participating today. God bless you all. Thank you very much. Back to you, Neha.
Thank you very much, sir. I'm sure we have so many experienced senior anesthesiologists with us, and the Yuva are definitely going to be benefited by your presence. So moving on, I would now like to invite the judges for this session, for the beginning of this session. So a quick introduction, sir has already introduced. So I would now like to invite Dr. Parul Jindal, ma'am. Ma'am is a professor at HIMS Dehradun. So her interests are difficult airway, pediatric anesthesia, PG teaching, calls, and she's an BLS and ACLS instructor. Dr. Parul ma'am is a GC member, National RSACP. She has been the president of the ISA Uttarakhand State from 22 to 24. Also the past president of the Dehradun Society of Anesthesiologists and vice president of the Central Zone ISA. She has been the organizing secretary for the Yuva ISACON 2024 and Uttarakhand ISACON 2024. She has sponsored various CMEs and has been the scientific chairperson for the 12th Central Zone ISACON. And ma'am has won the ISA President Appreciation Award in 2024, second prize for raising calls awareness individually, and has won the Research Paper Prestigious Award, Dr. Lalit Mehendiratta Award. Also, she's the winner of the ISA Proficiency Award in 2023, Dr. B.C. Roy Award 2023, IMA Dehradun Appreciation Award, and Diligent Award 2022 conferred by the ISA. Ma'am has a total of 70 publications, 805 citations in 14 highly indexed journals and 19 journals. So we welcome you, ma'am, to judge these young anesthesiologists.
Thank you, Neha. Thank you so much, dear.
Thank you, ma'am. Moving on, we have Dr. Swati Chhabra, ma'am. Ma'am is an additional professor at anesthesiology department at AIIMS Jodhpur, a very passionate neuroanesthesiologist. She has the Certificate of Excellence for standing first among the additional professors in medicine and allied specialties for publication of original research in high impact journals in the year 2024, which was held in AIIMS Jodhpur. She's also the Joint Secretary of RSACP and the recipient of the Proficiency Award in the ISA. Ma'am has 80 plus index publications, 8 book chapters, and 2 intramural grants as well. Congratulations, ma'am, and we welcome you to the Youth Conclave 2025.
Thank you, Dr. Neha. Thank you so much.
And our the final judge we have for today is Dr. Nishant Sahai, sir. Sir is a professor at AIIMS Patna. His areas of interest are research, methodology, airway management, and onco-anesthesia. Sir is in the editorial team of JOACP, PEAK at the ISA and the Airway Journal. He also is a sub-dean at the College of Indian Society of Anesthesiologists, member of ISA National Task Force COVID-19 Management, is the recipient of Best Reviewer Award for the IJV in the Airway segment, and he has been coordinating weekly ISA online postgraduate classes. A whopping 79 publications in the peer-reviewed journal and 11 book chapters. We welcome you, sir.
Thank you so much. It's an honor.
So, and now I hand over to Dr. Nitin Chaudhary to introduce our first speaker for the day.
Thank you, Dr. Neha. So we'll move on with our presentations for the day. Yeah, so the first presenter, we have Dr. Poonam Godwal. She is working as a senior resident at AIIMS New Delhi, and she'll be speaking on a topic on long-term benefits of ultrasound-guided erector spiny plane block on post-mastectomy pain syndrome in patients undergoing breast surgery, a randomized controlled trial. So over to you, Dr. Poonam. You may start your presentation, please.
Thank you so much, sir. Good evening, sir.
Dr. Poonam, before you start, shall we say something?
Yes,
We'll be judging you on 5 points: the content, the quality of your paper, the presentation, that is how well you are able to present your slides, how well you are able to communicate and explain the things, the question and answer session, and overall impact of your paper which it has on us. And each section will have around 10 marks, and the total of 50 marks will be there. And we'll be asking you questions. The presentation time is 8 minutes, and we'll take 2 minutes for the discussion.
okay, ma'am.
Right? Thank you
Yes,
so much.
ma'am.
So can we
Thank you,
start?
ma'am. Yes, ma'am. Starting my slides. Is it visible, ma'am?
Can you make it full screen, Dr. Poonam?
Yes.
Dr. Neha, will you be minding the time? Or
Yes, ma'am. Yes, ma'am. I'll give you a prompt when it's almost around at 7 minutes.
okay. Thank you.
Okay,
Shall I
ma'am.
start, ma'am?
Yes, please start.
Good evening, all. My research topic is to study the long-term benefits of ultrasound-guided erector spiny plane block (ESP) on post-mastectomy pain syndrome, that is PMPS, in patients undergoing breast surgery, a randomized controlled trial. So, nothing to disclose. Breast cancer is a leading cause of illness and death in women. PMPS affects up to 68% of the post-mastectomy patients. It is a neuropathic pain that persists for more than 3 months after surgery. Pathophysiology involves primary hyperalgesia, central hyperalgesia, and central nervous system inflammatory damage triggered by injury. It's not moving.
There must be markers in the left-hand side down in your slides. Just click that arrow thing. It'll move.
Dr. Poonam, just click on the slide and then it will move.
Yes, sir.
Move your cursor on the side, then it will move. Yes.
Yeah.
So it is a chronic pain for more than 3 months with the burning or stabbing or shooting pain associated with emotional distress and reduced quality of life. As of now, available treatment options are pharmacological, physical therapy, regional blocks, psychological, and complementary techniques. Amongst the regional blocks, interventional management, as per the literature, various blocks have been tried with varied success: intercostal nerve blockade, stellate ganglion block, pectoral nerve block, paravertebral block. And another potential target is the erector spinae plane block. Erector spinae plane block, that ESM muscle is formed by the spinalis, longissimus thoracis, and iliocostalis muscles, which provides ESP block provides analgesia by blocking ventral and dorsal rami from C5 to T6 dermatomes, with the advantage of ease of performing, analgesic efficacy, and low risk of complications as compared to conventional neuraxial techniques. So this is an ultrasound guided pictorial technique demonstrating the transverse process and the needle and the erector spinae muscle. As the drug is injected, we can see the separation of the facial plane and the spread of the drug. Regarding cancer recurrence, systemic recurrence is common despite extensive therapy. Neutrophils and platelets, they support tumor growth by releasing growth factors. Lymphocytes, they also help anti-tumor defense via cytotoxic and helper T cells. Circulating lymphocyte subset percentages may predict positive outcomes. Natural killer cells play a key role in tumor cell destruction. So hypothesis of the research is erector spinae plane block leads to the reduction in the incidence of the post-mastectomy pain syndrome. Regarding the research question, patients enrolled were 20 to 65 years undergoing elective unilateral breast surgery with axillary dissection, ESP intervention being the ESP block in addition to the standard treatment plan, comparison with standard treatment plan, and outcome is PMPS at 3 months follow-up by using short form Megil pain questionnaire. So primary objective is to assess the effect of the ESP block on PMPS at 3 months follow-up by using short form Megil pain questionnaire. Secondary objectives were 24-hour post-operative opioid consumption, pain scores, NRS, and duration of analgesia up to 24 hours, intra-op and post-op hemodynamic changes, incidence of nausea, vomiting, sedation, and complications up to 24 hours, neutrophil lymphocyte ratio, platelet lymphocyte ratio, helper T cells, NK cells, cytotoxic T cells, baseline, and 24 hours post-op values. Expression of leukocyte marker CD45, 3, 4, 8, 19, 16, 56 for cancer recurrence within 12 months recruitment and 6 months follow-up. So patients included were 20 to 65 years of age, ASA 1 to 2 scheduled for elective breast cancer unilateral surgical procedure. Excluded were those with patient refusal, skin infection at needle site, chronic infection, non-allergies to any of the study drugs, coagulopathy, patients on analgesics, mentally challenged patients, and patients with liver and renal dysfunction. For sample size calculation, as per the incidence from the literature, PMPS has incidence of 20 to 68%, and assuming baseline incidence of 50% at 3 months post-surgery, clinically significant reduction was 50% of baseline. So minimum sample size required was 60 patients per group. So this was an open label randomized controlled trial done at Department of Onco-Anesthesia and Palliative Medicine, BRA, IRCH, and NCI over a period of 18 months. Randomization was done using web-based program for block randomization with variable block size of 4 to 6 with allocation concealment using sequential sealed opaque envelopes containing group allocation. This is a flow diagram showing number of patients underwent breast surgery 254, out of which 134 were excluded in terms of refusal, receiving analgesics, chronic illnesses, and more than 65 years. So 120 patients were enrolled and 60 per group were enrolled and analyzed in each group. Coming to the results, baseline characteristics in terms of age, gender, body mass index, pre-op chemotherapy, ASA physical status, and surgical duration, they all were comparable. Coming to the primary outcome, PMPS incidence at 3 months and 6 months, it was much lower, 66% in the ESP group as compared to 93% in the control group with p-value of less than 0.01. Regarding the present pain intensity, VAS score, and pain rating index using short form Megil pain questionnaire, it was much lower in the ESP group as compared to the control group. Regarding the secondary outcomes, this is the box whisker plot showing 24-hour post-operative opioid consumption, which was much lower in the ESP group as compared to the control group. Then NRS assessment for pain at rest for various time points. Clearly, ESP has lower opioid consumption as compared to the control group. And NRS on movement also at various time points was much lower in ESP group as compared to the GA group. Regarding the hemodynamic parameters, both groups were comparable. And perioperative complications, nausea and vomiting, it was much higher in the control group as compared to the ESP group. Rest complications were similar in between the two groups. Regarding quality of life assessment, better quality of life in terms of self-care, usual activity, pain or discomfort was noted in ESP group as compared to the control group, which was assessed using European Quality of Life 5-dimension 3-level questionnaire. And inflammatory and immune profiles as measured by the parameters like neutrophil lymphocyte ratio, PLR, CD45, 3, 4, 8, 19 biomarkers, they were similar between the two groups. So the strength of the study, this is the first study comparing ESP block for effect on PMPS at 3 months and 6 months follow-up and assessed impacts on the quality of life and cancer recurrence. Limitation being applicable only in ESA 1 to 2, excluding high-risk patients, and inability to standardize post-operative pain therapies after discharge. So in conclusion, ESP block significantly reduced the incidence and intensity of PMPS at 3 and 6 months compared to control group, better outcomes in self-care activity and pain or discomfort domains, lower opioid use, and pain scores at rest and during activity were consistent at all measured time points. Thank you.
Thank you so much, Dr. Poonam.
Yes, ma'am.
A few observations from my side. They are one that you've taken a control group where you've not done any intervention. So how was the pain managed in these patients?
In the control group, we had the general anesthesia and we used the opioid sparing technique using the dexmed infusion. And intra-op hemodynamics, we maintained with the help of the inhalational sevoflurane and dexmed infusion that we used.
And post-operatively?
Post-operatively, we had used the PCA pump, patient-controlled analgesia pump, and it was applied to both the group of the patients, and we assessed for the post-operative opioid consumption, which was noted down in which group it was higher.
And it was higher in the control group.
Yes, ma'am. It was clearly higher, clinically significant, and higher in the control group.
You've used McQuill questionnaire, but
Yes,
it does
ma'am.
not compare the functional outcome. So after 3 months, did you use any? You could have used any questionnaire for functional outcome. That is just an observation
Okay,
from my
ma'am.
side. Thank you so much.
Thank you,
Over
ma'am.
to you,
Dr.
Swati and
Poonam.
Ishan.
Yes, sir.
Yeah. Dr. Poonam, this PMPS has a significant association regarding with, I mean, difference in the age group. Like younger women have more PMPS rather than the elderly. Also, there is a lot of research regarding the estrogen status. You have already measured all the CD4 counts.
Yes, sir.
How have you accounted for all of these factors? You know, certain estrogen receptor positives will have more PMPS.
Yes, sir. Sir, basically, we have enrolled those patients with the stage 1 to 2 cancers, triple positive biomarkers, so that patients enrolled were of modified radical mastectomy and excluded all those patients undergoing palliative mastectomy.
That is staging. But the type of cancer, have you accounted for the confounding that these cancers can produce? And secondly, the age also. The younger women have more PMPS. So why have you taken such a wide age group? Your presentation was really nice.
Thank you, sir.
Why have you taken such a big age group from 20 to 65? You have kept.
To complete the sample size also, and it was overall, sir, we wanted to assess what is the incidence in this age group. It is clearly mentioned also that it is much more higher in the younger population, but we wanted to generalize it, so we just use this age as the criteria, inclusion criteria.
Okay, yeah, Dr. Swati, please.
Yes, Dr. Poonam, very well presented. I have
you.
a question. How did you make sure that the ESP block which you gave was working?
Ma'am, we assessed after giving, it was given in the pre-operative room area, and we assessed for the sensory and motor symptoms also. We using the sensor temperature sensation and loss of cold or warm sensation. So we asked the patient, is it those sensory dermatomes have been achieved or not?
I
Before
hope the
proceeding to
motor
the
thing
general
which you said
anesthesia.
was slip of tongue. The motor, did you? Yeah. Was
Sensory,
there a
ma'am.
motor?
No,
Okay.
sorry, sensory.
Okay. So you had shown a graph showing how many were included and all. So
Yes,
can you
ma'am.
name that flow diagram? Which guidelines give you mandate you to put this diagram?
Yes, ma'am, consort flow sheet.
Okay, and which organization mandates the use of consort for RCT? Okay, no problem. And did you register your study with CTRI?
Yes, ma'am, I have registered under CTRI.
Okay, and are you going to follow these conclusions or clinical recommendations in your current practice?
Yes, ma'am, we have started. Yes, ma'am, we have started using ESP block for better post-operative analgesia and seeing the effect as the patients come in the OPD for follow-up. We usually assess them for post-mastectomy pain syndrome.
Can you name a few blocks which have been compared with ESP? Because
Yes,
you compared with control group. Yes.
Yes, ma'am. As per literature, serratus anterior plain block versus pectoral nerve block, paravertebral block, they all have been tried.
Okay, thank you so much.
Thank you, ma'am.
Right. So we'll move on to our next presentation. I would like to invite Dr. Divya Wadhwa. She's working as a senior resident at DMCH Ludhiana, and she'll be talking on the evaluation of the role of pre-medication with dexmedetomidine on emergence agitation in patients undergoing laparoscopic abdominal surgeries. Over to you, Dr. Divya. Dr. Divya, are you there?
Am I audible?
Yeah, you're audible now. Can you please share the presentation?
Yes. It says that host has disabled the attendee screen sharing.
You can do that. You can share it right now. You've been made the co-host. Go ahead.
You are the co-host now.
Is it visible?
Yes, it's visible. You can just put on the slide mode. Yeah.
Okay. So, good evening, everybody. My topic
Can you start with the slideshow? It's still not in the slideshow mode.
The play button that is there in the bottom toolbar of the screen. The orange play button.
The orange play button, can you see?
No, I have.
Yes.
Fine.
No,
So shall I
not yet.
start?
No, it's still not in that mode.
So
The orange button.
I have clicked on the orange button. It says.
Or else you can just go on the slideshow about on the bars. Slideshow, and you can start from beginning. Yeah, from beginning. Just next. Yeah, you can start.
Visible?
No, it's still not coming in the full screen.
It says full screen on my side.
Can you just share it again? Just remove it and share it again. I think there's some glitch in the. You can stop sharing and you can again screen share and just see if it works this time.
Is it visible now, sir?
No, it's the same. It's showing the same thing. Yeah.
Can we start with the next presentation?
Yeah,
We'll give
Divya, can you take somebody else's laptop and we will move to the next speaker, I think.
Yeah, we can do that.
Wait a minute, I think I got it. Now?
Yes.
Yes. Perfect.
Yes. Perfect.
Perfect. Go ahead. Yeah.
Shall I start?
Yes. Start.
Okay, my topic is to study the effect of dexmedetomidine pre-medication on emergence agitation. So what is emergence agitation? Miller says that it is the temporary post-anesthesia stage, which is characterized by agitation, confusion, distress, violent movements, and it is particularly within 60 minutes after GA, and during extubation within 5-10 minutes it is the maximum amount. So what are the factors that influence it? So basically the type of surgery it is, the age, the gender, and the preoperative anxiety scale, and the anesthetic agents which are used, especially if we're using inhalationals like sevoflurane. Another factors which are going to be affecting it is going to be pain, hypothermia, invasive devices, bladder distension, and the carbon dioxide absorption. What is the clinical impact of this emergence agitation? So basically it is not good for the patient. It can lead to self extubations, catheter removals, aspiration, and cardiovascular instability, and also it tends to increase the recovery time and the healthcare costs. So there are various assessment tools which are used basically to assess the emergent agitation. The assessment tool that I used in my study was Riker sedation and agitation scale, which is a 7-point scale, where more than 5 means that the patient has emergent agitation, and 1, 2, 3 means if they are sedated, and a score of 4 means that the patient is fine and well oriented. Now, there are various prevention and treatment strategies for avoiding emergence agitation, which has certain non-pharmacological and certain pharmacological aspects. So these are the non-pharmacological aspects, which means we can educate the patient, we can have the parental presence in the pediatric cases, and in the pharmacological agents, we've got propofol, opioids, ketamine, magnesium. But every agent has got its advantages and disadvantages. I use dexmedetomidine as a pre-operative infusion in my study, which is highly effective, has anxiolytic, sedative, and analgesic properties, reduces the opioid use, and also I had used it as a measure to reduce the pre-operative anxiety in the patient, which further would lead to decrease in the emergence agitation. So the aims and objectives of my study were: the primary objective was to evaluate the effect of preoperative intravenous infusion of dexmed on emergence agitation, and the secondary objective was to study the effect with dexmed on the hemodynamic parameters and adverse effects, if any. In the material methods, it was a randomized double-blinded control trial. I had taken 140 patients who were of ASA 1 to 3 and aged 18 to 65 years of age, who were undergoing the elective laparoscopic abdominal surgeries under general anesthesia. In the exclusion criteria, we had patients who were having severe systemic diseases with a BMI of more than 35, or who were on another psychotropic drugs, substance abuse, or who had allergy to the drugs. So there were two groups that had been made: Group D, which was the dexmed group, the intervention group, and Group N. In Group D, we had given infusion of 20 ml over 20 minutes in the dose of 1 mics per kg of dexmed, while in normal saline it was 20 ml NS, which was infused over 20 minutes. Throughout that 20 minutes, there was monitoring which was done of the patient in the preoperative area, because I was using dexmed as a preoperative infusion. So ECG, saturation, non-invasive BP, everything was monitored every 5 minutes during that drug infusion. And then we had monitored the preoperative Riker agitation sedation scale of the patient, which was taken before the induction of the patient. So there was a standard anesthesia technique which was followed, we had given pre-medication with benzodiazepines, fentanyl. Induction was done using propofol, etracurium, and maintenance was done over oxygen, air, and sevoflurane. And the observation and data collection, we had assessed the emergence agitation using the Riker sedation scale. It was done at 3 points, which was immediately post extubation, every 5 minutes till the patient we had given a verbal response, and after the entry into the post anesthesia care unit. So I had taken time intervals. T0 was the time when the sevoflurane was stopped, T1 was the time when we extubated the patient, and T2 was the time when there was a verbal response to the patient. So by that, we calculated the emergence time between the two groups also. In the primary outcome of my study, we had taken the incidence of emergence agitation, and in the secondary outcomes, we had seen what was the severity of that agitation, what was the time of emergence, and the hemodynamic changes. So sample size and analysis was done on the prior data, which was done by the study of Toy et al. In 2021, and 70 per group we had taken the sample size. So this was the concert. And then among the two groups, the demographic data, which included age, gender, height, weight, they were comparable. The ASA grades were comparable between both the groups, and the comorbidities were comparable. Preoperative findings were also comparable between both the groups, which we had calculated while the dexmed infusion was going on in the preoperative area. The intraoperative findings in group D and N. So while the patient was taken in the OT and induction was done, so there was significant differences which was seen in the heart rate, and it was at before induction, after induction, and at 5, 10, 15 and 20 minutes of intraoperative time while the pneumoperitoneum was being achieved. So dexmed infusion had a better hemodynamic response while the pneumoperitoneum was there, and had a better response to the pressor response of the patient. So it had significant p values, and we can see that there is a better group D response at the heart rate during the initial time. Then the intraoperative systolic blood pressure and the diastolic blood pressure both had a better response when the pneumoperitoneum and the pressor response was there. Then we come at the emergence agitation. So the incidence of emergence agitation in the group D was 2.9%, while in group N it was 48.6%. So we had concluded that group D had a significantly lower incidence of EA with the p value of 0.001. The severity was based on the RAS score, which is the Riker agitation sedation scoring. So pre-operative time at 0 minutes post-extubation, at 5 minutes post-extubation, there were significant p-values. However, 10 minutes post-extubation, the values were lower, but it did not come out, the p-value did not come out to be significant. Then emergence agitation and age. So we had divided the patient into two groups, which were less than 40 years and more than 40 years. However, in group N, more EA was there in both the age groups. In group D, only one patient was there in each group, which was not significant. So it was not a significant value with EA with age. EA and gender. So males had a significantly higher emergence agitation.
You have 1 more minute, Dr. Divya.
Okay. So extubation and emergence time. So the significantly it was more in group D. The extubation time, that is T1, and the emergence time. So there are various authors who have done the study, which was Rim et al. Rim et al. Had done the study, which he said that there were behavior would range from confusion to aggregation, and then he had concluded that the incidence of EA refers from 0.25% to 90.5%. Then the role of preoperative anxiety. So there are various studies which had concluded that preoperative anxiety is a major risk factor for EA, and my study had said that due to the use of preoperative dexmedetomidine, which is an anxiolytic, it decreases the preoperative anxiety, which significantly contributes to decrement in the emergence agitation during extubation. So this was the incidence which I had told earlier, and this is the RAS scoring. Thank you.
Thank you, Dr. Sir. And my question is, what is the difference between emergence agitation and emergence delirium?
Ma'am, in emergence delirium, it is said that there are violent behaviors of the patient, which is also affecting their cognitive mechanism. But in emergence agitation, their cognition is not affected.
Okay, good. And can you name any other scale which can be used for measuring agitation?
Ma'am, there are various scales which are used. One is Riker agitation sedation, which I had used. Then there is another scale called as PEDS ICU scale, which is used in the pediatric patients. Then there is CAM ICU scale, which is used in ICUs. Then there is another scale which is Ramson's
Richmond-Admin scale.
Richmond's scale. Yes, ma'am.
Right. And what was the power of your study, and how was the sample size? How were the patients divided in the two groups? Randomization.
The patients were divided into two groups as 70 and 70, and we had taken the 10% dropout rate. The sample size was of 140 patients, and it was a double-blind study using software.
So I want to ask you, how was randomization done? How did you randomize them into two groups? That which patient will receive dexmedetomidine or which patient will go into the control group? How was that decided?
Ma'am, it was like the the nurse would pick up a chit and it was done on that system. It was a blinded study, so then another person would start with the infusion.
Okay. And who prepared the infusions? Was the person involved later on with the study?
No, ma'am.
Right. Dr. Nishant and Dr. Swati, over to you.
Yeah. Just to continue on that sample size, how do you calculate the sample size? Can you just elaborate, please? It was based on
Sir,
the study by Choi et al.
Yes, sir. So the primary study was taken by Choi et al., which was done in 2021. We had taken at that.
What was his primary objective?
Sir, that study's primary objective was to calculate the incidence of emergence agitation only.
Okay. And that age group was the same?
Yes, sir.
The difference that you mentioned between the emergence agitation and emergence delirium.
Yes, sir.
That is along a spectrum of the neurocognitive disorders. Can you just elaborate the neurocognitive disorders, how the spectrum goes? Because this is important for your study. That is a part of your thesis, now. This research.
So it goes like first when you extubate the patient, it can go from agitation, from a violent behavior like agitation to up to delirium. So there is a
so with
ladder.
delirium, do you think there is cognitive defect in the cognition also? That as you mentioned, do you think with delirium there will be a defect in cognition?
So the delirium is defined as there is a cognitive impairment to the patient, then it lands up to delirium. It involves the impairment in the cognition.
Yes, that is a separate topic. Cognition, when you say there is a defect, you have to measure it and before operation also. Regarding your study, did you just give the dexmedetomidine as a pre-medication, or did you continue throughout the surgery?
Sir, no, I had given it as a preoperative infusion only. We did not use it in the intraoperative period. My thesis was to see if the preoperative infusion would decrease the preoperative anxiety of the patient, which could affect the emergence agitation while after extubation.
So do you think it can be continued during surgery also?
Sir, it can be continued during surgery also. There are many studies who actually have continued it during the intraoperative time also.
Yes, Dr. Swati, ma'am.
Yes, Dr. Divya, can you tell me the risk factors of emergence agitation?
Ma'am, there are various risk factors depending on the surgery. For example, nasal surgeries have got a higher chances of emergence agitation as compared to another surgeries. It could also be affected by gender. There are other studies which also say that it is affected by age, but in my study, the age did not come out to be significant. It also depends on the anesthesia we are using. For example, inhalationals increase the incidence, while if we're using Vitiva or we are going with infusions, it decreases the incidence. Then it also depends upon the preoperative counseling of the patient.
You said the age, what age or below what particular age? What is the cutoff where the emergence agitation increases?
Ma'am, it is said that in the elderly age group who are more than 65 years of age, and in the younger age group that is less than 18 years of age, there is increment in the emergence agitation.
Okay. Right. That's all from me. Thank you.
Thank you, Dr. Divya.
Thank
so
you.
We'll move on to the next presentation. The next speaker, we have Dr. Leena Mariam. She's working as a senior resident at DMCH Ludhiana, and she'll be speaking on the research topic entitled The Effect of QCon Index Monitoring versus the End-Tidal Sevoflurane Monitoring on the Tracheal Extubation Time, a comparative study. Over to you, Dr. Leena.
Thank you so much for inviting me today for speaking. So I'll just start the presentation. Sorry, 1 second. All right. Thank you so much, and good evening to everybody and all the speakers. So my presentation basically is on a randomized control trial of the effect of QCon index monitoring versus end-tidal sevoflurane monitoring on the tracheal extubation time. So we all know that extubation, like how we describe it as taking off on a plane and landing a plane. So extubation is usually the tedious end of like a smooth general anesthetic. So sometimes if we have delayed extubation time, that can like hinder the list and cause problems for the patient as well. So what I did is I investigated using QCon, which is Conox, which is a process ECG, versus end-tidal sevoflurane anesthetic gas monitoring to see the difference in the anesthetic depths. So I estimated the end-tidal anesthetic gas concentration from the anesthetic machine, and I calculated the MAC value delivered to each patient. And then I used, in the other group of patients, I used a Conox monitor. So it's a process encephalogram, which is just like our BIS monitor, but it's a modified version. So it gives us a QCon value, and that QCon value ranges for 40 to 60 with consistent adequate surgical anesthesia. So above 60, the patient would be in either sedated position, 100 means the patient would be awake, and less than 40 will be too deep of anesthesia. So I compared the two, and I gave sevoflurane-based general anesthesia, and I calculated the extubation time. That was my main aim. And as you can see, this is the Conox machine, which is a little different from the BIS machine. It is a little more sophisticated. My other objectives were, other than the tracheal extubation time, was to compare the percentage use of sevoflurane in each group. So what I took in the materials and methodology, I took around 100 patients, ranging from ASA 1 to 2, and we gave them sevoflurane and nitrous oxide-based general anesthesia. And we took elective cases only with less than 3 hours duration of time. So we grouped them into group 1 and group 2. So group 1 was the end-tidal anesthetic group. They received sevoflurane oxide, and their MAC value was maintained between 0.7 to 1.3. And the QCon value was also monitored for these patients, but the anesthesiologist was blinded to it. The other group, the QCon group, they again received the same sevoflurane nitrous oxide-based anesthesia, but the surgical anesthesia was basically focused to have the QCon value between 40 to 60. And again, the anesthesiologist was blinded to the MAC value on the monitor. So in group 1, our end-tidal anesthetic group, we had an extubation time of 7.79 minutes with a standard deviation of 3.41. But whereas in QCon group, the extubation time was 2.24 minutes with a standard deviation of 0.99. As you can clearly see, the QCon group had a significantly less extubation time. The p-value was equal to 0.001, and there was approximately a mean difference of 5.55 minutes between the two groups. This graph shows the extubation time in the end-tidal anesthetic gas monitoring patients, and group 2 was the QCon group. The second thing that we also monitored was the percentage of sevoflurane use. And in group 1, it was 1.26%. Whereas in group 2, our QCon group, the percentage use was 0.86%. Again, this is another graph where you can see throughout intraoperatively how much sevoflurane was approximately used. And it was much, much higher in the end-tidal anesthetic group. And there was a significant p-value. And you can see the blue one shows our end-tidal anesthetic group, where it's always higher than our red line, which is our QCon group. So the conclusion of this is that this study highlighted that the significance between the extubation time of the two monitoring methods and the sevoflurane percentage used. So the QCon index monitoring obviously shows more promising anesthetic management for even our routine cases. I know we do use the BIS monitor, the Conox monitor, the SedLine in our ICUs for sedation, in neuro anesthesia, but in normal patients who are going on an elective list, like our ENT patients that we took in this study, or our routine laparoscopic cholecystectomies, or other sort of surgeries, we saw that using these QCon monitoring, we can significantly reduce our sevoflurane percentage usage, and we can significantly decrease the extubation time. Okay, thank you.
Thank you, Dr. Mariam. My question is that there's a difference of about 5 minutes between the two.
Yeah.
So first of all, what is the cost of using a QCon for every patient?
So the cost of using the QCon monitor is that first is the monitor itself, which is around 4 to 5 lakhs, but that's a one-time investment to the hospital. And then we have our, the leads that we put in each patient in the sensor that costs around 1,500. But they say not to use it for other patients, but you can reuse that sensor for other patients, so the cost can significantly reduce according to that.
And the difference between the two groups is 5 minutes. Do you think it is clinically very significant difference?
Yes, I guess that's a really good question. It is clinically significant because that's a little faster, although still it takes us time to shift the patient, and obviously but still that shows that promising effect that, using less sevoflurane. And more than that, it also overall reduced the costs because the percentage of sevoflurane we use. So we're using less anesthetic gases, less complications like post-operative delirium, less, nausea, vomiting. So, I think it is, even if the tracheal extubation time is a little less, I think overall it does provide other benefits as well.
So these could be your secondary objectives. If the first objective was the extubation time, these could have been your secondary objectives. My second query is that have you converted the percentage of sevoflurane used into the ml of sevoflurane used?
So I think that's one thing that we could have done in this study. Definitely, that's an amazing question. Yeah, but I think we can do that for the next studies that, on this sort of topic.
Okay, thank you so much.
Thank you so much.
Thank you, Lena. That was a nice presentation. Now,
thank you.
Have you monitored any intraoperative awareness in any of the groups?
So interoperative awareness was monitored by this monitor. If the range is between 40 to 60, that means the patient should not have awareness, and in the QCon value. And then the MAC value we've seen overall, because MAC value has been used for ages and ages, it's shown that between 0.7 MAC to 1.2 MAC, there is less incidence of interoperative awareness.
My concern is if you're using the use of sevoflurane is reduced, there are chances of awareness. Did you find this problem in any of the patients?
No, we didn't find. Yes. So post-operatively, we did ask every single patient about did they have interoperative awareness, but no such complication was seen in any of the patients, thankfully.
And if you titrated your sevoflurane solely based on the QCon index, what did you do if the hemodynamic changes were there? Suppose the patient was having hypertension. Did you alter the sevoflurane concentrations?
So in those sort of patients, we saw what was maybe the underlying cause of that hypertension. Were they already hypertensive beforehand? So we gave them a supplement of, for example, labetalol or esmolol. Were they in pain? So we gave them a supplement of fentanyl. So we tried to find the cause of the hypertension in those patients rather than increase the dose of sevoflurane.
So you manage the hemodynamic changes by not changing the sevoflurane concentration, but by using other methods like beta blockers and all.
Yeah, beta blockers and fentanyl and all the other.
That was captured in your protocols.
Yeah. Yes. Thank you, sir. Yes. Thank you.
Thank you, Dr. Swati ma'am.
Yeah. Thank you, Dr. Lena, for the presentation. My question is, you standardized your anesthesia using QCon values 40 to 60. Just wanted to know what clinical conditions or what pharmacological agents can, give you a false high or low reading of that 40 to 60?
So 40 to 60, this was actually, it's a really great question. These were actually the exclusion criteria that we took, like things that could elevate the QCon value. Like, for example, somebody with epilepsy or any neurosurgical problems, had neurosurgery before, where we could have like false readings of the QCon value. So those patients were excluded from the surgery because, again, at the end of the day, it's a process EEG. So anything that could, increase or decrease the EEG, we excluded those patients, like more bound patients, patients who were already in a coma, all those sort of patients, like ASA 3 and 4 patients, basically.
And what pharmacological agents can lead to these changes?
Again, every sort of all our anesthetic drugs, they do affect the QCon value. Like if we give too much fentanyl, like too much opioids, they can decrease the QCon value. So we gave it according to, just the, 1 to 2 mics. We standardized that for all the patients, like 1 to 2 mics at induction dose. Excessive use of propofol could have an decrease in the QCon value. So again, in the induction dose.
So sorry to interrupt you, Dr. Leena. So that is unexpected that you give propofol and the value goes down. I'm saying like patient is in a deeper plane, but it gives you a false high number or a false low number.
Mm-hmm. Again, the QCon machine is again regularly calibrated. One thing good about that machine is that another thing that could increase or decrease the value is if the sensors are not sticked properly to the patient. So there's a calibration machine that tells you the
Can you tell me what nitrous oxide, dexmedetomidine, and ketamine do to this number?
So ketamine increases, as we all know, it increases the QCon value. It causes increased brain activity. Nitrous oxide doesn't really have much effect that the studies that I've seen. And I think dexmedetomidine, I'm not really sure about that dexmedetomidine, but again, since I don't think it should have a value, but we didn't use it in any of the patients.
And what do hypotension and hypertension do to that value?
Hypotension and hypertension, again, I think they unless it decreases the blood flow to the cerebrum, like hypotension decreases the blood flow, it shouldn't really have an effect. But hypertension could decrease the value if there's like decreased blood flow to the to the brain. Again, then there could be difference in EEG.
Okay. Thank you very much. That's
Thank
all
you
from me.
so much. I hope that answered your questions. Thank you.
Thank you.
Thank you.
Thank you, Dr. Leena. So we'll move on to the next presentation. Next presenter is Dr. M. Akhilesh. He's working as senior resident at Nizam Institute of Medical Sciences, Hyderabad, Telangana. And he'll be presenting his study entitled Diaphragm Ultrasound to Evaluate the Therapeutic Effect of Theophylline Trial. Over to you, Dr. Akhilesh.
Thank you, sir. So it is showing host-disabled participant screen sharing.
Okay, we'll just make you a co-host. Just give us a second.
Okay.
Done. You can go ahead now.
Yeah.
Okay. Good evening, everybody. My topic is diaphragm ultrasound to evaluate therapeutic effect of theophylline and antioxidant in ARDS, a randomized control study. According to the Berlin definition, acute respiratory distress syndrome is diagnosed based on the following criteria. Based on the onset, symptoms must develop within 1 week of clinical insult or worsening respiratory symptoms. Based on the imaging of chest X-ray, there should be bilateral opacities which are not fully explained by any conditions such as effusion, lobar collapse, or nodules. Respiratory failure, the condition must not be solely attributed to cardiac failure or fluid overload. Hypoxemia, defined by PaO2 by FiO2 ratio, with a minimum peak requirement of more than or equal to 5 centimeters of water. which are further categorized into mild ARDS with PF ratio of 200 to 300, moderate ARDS with PF ratio of 100 to 200, severe ARDS with PF ratio of less than or equal to 100. Theophylline is a drug which is known for its bronchodilatory and anti-inflammatory effects. It significantly improved diaphragmatic strength and endurance, which was measured using transdiaphragmatic pressure during inspiratory efforts, indicating an enhancement in diaphragm contractility. Vitamin E is a fat-soluble antioxidant known for its role in mitigating oxidative stress and helps to maintain immune function. Diaphragm function is a major determinant of weaning from mechanical ventilation in intensive care unit patients and influences the duration of mechanical ventilation. It is involved in the shock-related generalized organ failure. Diaphragm dysfunction can occur in critically ill due to mechanical ventilation associated with a time-dependent decrease of diaphragm strength called ventilator-induced diaphragm dysfunction. Diaphragm ultrasound allows for real-time visualization of diaphragmatic movement and muscle contraction, which is crucial for diagnosing conditions like diaphragm weakness and paralysis. My novelty of this study is there is no study which could predict the rate of diaphragmatic dysfunction in increasing severity of ARDS and effect of drugs which can improve the diaphragm function using ultrasonography. My aim is to evaluate the therapeutic potential of theophylline and vitamin E in improving the diaphragm function in patients with ARDS using diaphragm ultrasound as a non-invasive monitoring tool. Primary objective is to determine the effect of adjunctive theophylline and vitamin E therapy on diaphragm contractility over time in ARDS patients, which is assessed through serial diaphragm ultrasound measurements. Secondary objectives are to determine the length of ICU stay with the need of invasive mechanical ventilation, to determine the length of hospital stay, and to determine the titration of inotropes. Study type and design is a randomized control study. Participants were recruited within the Nizam Institute of Medical Sciences after Institutional Ethics Committee approval, following their admission into the ICU from September 2022 to 2024. The patient met the eligibility criteria. The inclusion criteria is clinical history and investigations that support the diagnosis of mild to moderate ARDS with an age over 18 years and upper age limit of 70 years. Exclusion criteria include pregnancy, traumatic brain injury, phrenic nerve injury, long-term use of steroids like more than 3 months, space-occupying lesions of the liver, severe ascites, abdominal surgeries, and patients on renal replacement therapy. Patients with mild to moderate ARDS were grouped into two groups. The first group was control group, which received only the standard treatment for ARDS. The second group, which is the experimental group, they received theophylline and vitamin E after informed consent, apart from the standard treatment, starting from day 1 of intubation till day 3. Theophylline dose was 3 to 6 mg per kg, which was added in 100 ml normal saline and given intravenously over a period of 20 minutes. While vitamin E, which is 400 international units per day, was given via NG tube. Diaphragm ultrasound was performed on day 1 and day 3 of intubation 4 hours after theophylline and vitamin E were given. On the day 1, theophylline and vitamin E were given 2 hours after the intubation and thereafter every 24 hours later. So there are two ways of doing a diaphragm ultrasonography. One is using a convex transducer and another is using a linear transducer. We use linear transducer in the 8th to 10th intercostal space along the anterior axillary line, and we can see diaphragm as a trilamina structure. The trilamina, one is the pleural reflection, the second is the peritoneal reflection, which are hyperechoic and a hypoechoic muscle mass. And the patient should be asked to take a deep inspiration, and at the end of inspiration, thickness at the end of maximum expiration. The image acquisition should be static. And these are the imaging findings and the cutoff. Hemidiaphragm thickness is assessed by measuring the muscle thickness at end expiration, and the lower limit is 0.15 centimeters. Contractility ratio is defined as thickness at maximum inspiration divided by thickness at expiration, and the lower limit is 1.2. Thickening fraction is defined as end inspiratory thickness minus end expiratory thickness by end expiratory thickness, and the lower limit is 20%. Statistical analysis were conducted using IBM SPSS software. Descriptive statistics were used to summarize the data. Group statistics and tables are generated to provide the mean, standard deviation, and sample size. Levine's test for equality of variances was conducted to assess the assumption homogeneity of variances. Independent t-tests were performed to compare significance of p-value 0.05 with p-value in between 0.05 to 0.1, moderately significant with a p-value is between 0.01 to 0.05, and strongly significant if the p-value is less than 0.01. So this is the result. The first one is the consort diagram showing assessed 70 patients were assessed for the eligibility, 9 were excluded because of the death on the day 2 of enrollment into study, and 61 were randomized, and 30 were allocated to intervention A, which is group 1, and the 31 were allocated to group B and analyzed in group 2. The first diagram shows the comparison of significant biochemical parameters on day 1 and day 3 of intubation. Significant findings are in group 1. On day 3, the total leukocyte count is increased compared to the group 2. Similarly, SGOT is also increased in the group 1, decreased in group 1 compared to group 2. With respect to the age, comorbidities and addictions, there were not much of significant differences between both the groups. With respect to days of ICU stay requiring invasive ventilation, group 1 patients required almost a mean of 5.5 days of ICU stay requiring mechanical ventilation. On the other hand, group 2 required only 3.8 days. Days of hospital stay was more for the group 1 patients compared to group 2. And the inotrope requirement percentage decreased statistically significant for the patients of group 2. This is an error bar showing diaphragmatic thickness, contractility ratio, and thickening fraction. The above one is for the right hemidiaphragm. The below one is for the left hemidiaphragm. And we can see the blue whiskers are for the group 1. We can see a significant decrease in the diaphragmatic thickness on the day 3 compared to day 1. On the other hand, group 2 patients decreased much. Likewise, even the contractility ratio decreased for the group A and also the thickening fraction. On the other hand, for group 2, the contractility ratio and the thickening fraction did not decrease much.
Dr. Akhilesh, you have 1 more minute.
ARDS is a severe condition with high morbidity, and diaphragm dysfunction plays a key role in prolonged ventilation and poor outcomes. Diaphragm ultrasound is a useful tool to assess the function and predict weaning success, especially in detecting early ventilator-induced diaphragmatic dysfunction. The combination of theophylline and vitamin E significantly improved the diaphragmatic contractility and reduced ventilator-induced diaphragmatic dysfunction in ARDS patients compared to standard treatment. My study limitations include small sample size, single-center design, and lack of standardization, ultrasound protocols, highlighting the need for larger control trials. Conclusion is that the diaphragm ultrasound proves to be a valuable tool in monitoring these improvements, providing real-time feedback on could play a crucial role in enhancing the patient outcomes. My study was done in 2022. As you are seeing, according to the new global definition in 2023, they have included lung ultrasound also as a part of diagnosis of ARDS. Hopefully, in coming years, they might also include diaphragm ultrasound to actually evaluate and categorize ARDS patients into mild, moderate, or severe, and thereby uh, thereby uh, following any criteria to extubate the patients. Thank you.
Thank you so much. And
Thank you.
Dr. Akhilesh, my question is that was the study registered in clinical trial registry?
Yes, ma'am, it is registered now.
None of the participants so far have mentioned the CTRL numbers. One thing, Dr. Akhilesh, what is Helsinki Declaration?
It details on it deals with the human experimentation without any prior permission from the ethical committee approval, and also without any registration from the clinical trials with respect to usage of medicines. It says about that you have to take permission from all the ethical committee to use any drug on human experiment.
And especially this is designed for the vulnerable group, the female ladies and the children.
Yes.
Yes. My co-judges, please.
Yeah. Is that it might be an oversimplification to state that vitamin E and theophylline have an effect on the ARDS? There are so many confounding factors. Do you think that the underlying cause causing the ARDS would have a significant effect on the on this diaphragmatic movement?
Yes, sir. Because ARDS, if it we look at the pathophysiology, it is categorized based on the pulmonary etiology and non-pulmonary etiology. So our participants were all of the patients were registered from respiratory ICU because all of the patients were having etiology of pulmonary mechanism, mostly pneumonia. Had it been an extrapulmonary ARDS, like an acute pancreatitis, or any liver injury, or any kidney injury leading to ARDS, the outcomes would have been different because even for theophylline, the metabolism is mainly in the liver. For vitamin E, because it is a fat-soluble vitamin, it requires pancreatic enzymes for its metabolism. So, had it been an extrapulmonary cause, the therapeutic level of these drugs might have changed in the serum levels. So, we would not have been expecting these results because my study standardized the standardized how the patient's baselines were. Uh, uh, uh,
Yes, because the variety, the etiology of ARDS is quite varied. Just to it might be an oversimplification. In any case, your measurement, were you able to measure the diaphragmatic movements accurately in all patients, considering that there might be some obese patients? How many were the dropouts?
So there were 9 dropouts, sir. As you said, many of the patients actually succumbed to ARDS on day 2 of enrollment. 3 patients were very obese patients in which we couldn't actually identify the diaphragmatic thickness with a linear transducer. We could have used the curvilinear transducer, but to standardize the protocol, we only used measuring the linear transducers. So
Yeah, so
with the
one
linear
problem that
transducer,
such type of studies have is that 0.1 difference between one observer and a second observer will have a very significant difference in the results.
yes, sir.
So ultrasonographic measurements inter operator variance has to be taken care of. How did you ensure that?
So we measured the diaphragmatic thickness. There were three measurements were taken, sir. First measurement was taken by me, second was my co-guide, and third was my another co-guide. So we used to take 3 readings. All of them would have been blinded. We never know how much thickness was there. And we would have averaged those 3 measurements. And then the average of the 3 measurements were taken as the one measurement.
Okay. Thank you, Dr. Swati, please.
Yeah, thank you. Dr. Akhilesh, I just made an observation that the first line of your conclusion said that ultrasonography is a valuable tool. So, did you
Yes.
study the role of ultrasound or were you comparing the drugs?
We are comparing the drug point of action of those drugs were basically to improve the diaphragmatic contractility. And the diaphragmatic contractility, earlier when theophylline was studied, whether it will improve the diaphragmatic contractility or not, they use transdiaphragmatic pressure, which means they use a catheter to pass into the esophagus and then measure the pressure differences between intra-abdominal and intrathoracic pressure. But here we are measuring the effect of theophylline in affecting the diaphragmatic contractility by using the ultrasonography. And this was not done earlier. So we are using
Oh, but
ultrasonography
you
as a
used
tool.
diaphragmatic ultrasound in both the groups, right?
We did use in both the groups. Yes.
So you were not studying it. So you should refrain from concluding whatever you were not studying. So diaphragmatic ultrasound was a tool to study the changes and effect of both the drugs on patients with ARDS. But per se, you were not evaluating diaphragmatic ultrasound as a tool. So please refrain in future from concluding whatever you have not studied. Have you published this study?
No, not yet, ma'am. We are in that phase now. We are publishing.
Okay. My another question is, what were the limitations of this study and why couldn't you overcome them?
Ma'am, one limitation, ma'am, as sir said, the hemidiaphragm thickness is 0.15 centimeters, the lower limit. So if it is 0.14 centimeters also, it will come into the category of diaphragmatic dysfunction. So had it been the measurements given in 3 decimal points, like 0.150, 0.149, 0.148, that would have been more statistically significant. But most of the ultrasound, they give only up to 2 decimals. Like we use sonocyte ultrasound, it gave only up to 2 decimals. And that is the reason why even 0.01 centimeters of decrease in the value of the hemidiaphragm thickness, it would have shown into the hemidiaphragmatic dysfunction category. That was the
Okay. Okay. Right. My last question is, what were the strengths of your study?
Strengths of my study is that the earlier studies which they studied on diaphragmatic contractility, the sample size were almost 24 to 30. Our sample size is almost 61. So it is the much higher sample size compared to the previous studies. But again, this sample size is not sufficient enough to state that theophylline and vitamin E is definitely working. Also, because it is a combination of two drugs, we never know that because of which drug the contractility has been increased. The own aim was to address all the pathophysiology of ARDS. Like vitamin E
Okay.
takes care of
That leads to another question. Suppose your sample size is estimated to be 60 and you include 100 patients in analysis. Will that is that good or not? And why?
No, ma'am. That would oversimplify the data just to prove that would come into an observational bias.
Okay, thank you.
Thank you.
Thank you, Dr. Akhilesh.
Thank you, sir.
So we'll move on to the next presentation. I invite Dr. Jain Roy. He's working as senior resident in SGPGI Lucknow, and he'll be presenting his topic on the clinically predicted anticipated difficult mass ventilation and its actual occurrence determined using a capnographic grading-based objective scoring system, an observational study.
Good evening, everyone. Am I audible?
Yes, you are. Please share your slides, Dr. Jain.
Yes, you're audible, Jay.
Okay. Today my topic is clinically predicted anticipated difficult mass ventilation and its actual occurrence determined by using a capnographic grading-based objective scoring system, and it's an observational study. And the study is done in AIIMS Jodhpur. So we all know that face mask ventilation is an essential skill in airway management. The incidence of difficult mask ventilation is approximately 2 to 6 in 300 patients. So anticipation and documentation of difficult mask ventilation is important in patient care. So during preoperative airway assessment, there are certain individuals and group indices like bones and bones criteria to anticipate the difficult mask ventilation. We also know that capnography is an important tool to confirm the ventilation. In 2016, Nielsen and Lim suggested an additional important use of capnography as an objective indicator for the effectiveness of bag and mask ventilation. So they noted that the presence of a plateau in the capnographic waveform, like in grade A, indicate effective mass ventilation, whereas grade C and D, no plateau was present associated with inadequate ventilation. Based on this, we developed a novel objective capnographic scoring system which include the objective capnographic scoring system include the capnographic grading, the number of hands required for mass ventilation, and the use of airway adjuncts. Using these parameters, we categorize mass ventilation as follows. Score 2 to 3 indicates easy mass ventilation, score 4 to 5 indicates a difficult mass ventilation, and score more than 5 indicates a very difficult mass ventilation. And assessments were performed before as well as after the administration of the neuromuscular blocking drug. So our aim was determine the actual occurrence of the difficult mass ventilation using objective capnographic scoring system in clinically predicted anticipated difficult mass ventilation. And our primary objective was association between clinically anticipated and actual difficult mass ventilation using objective capnographic scoring system. And our secondary objectives were compare the objective capnographic score before and after administration of the neuromuscular blocking drug, internally validate the objective capnographic scoring system with subjective assessment of mass ventilation, and assess the assessment of the choice of the neuromuscular blocking drug. So it's an observational study, and total study duration is 1 year, 8 months, and it's registered in clinical trial, and included those patients who are adult more than 18 years of age with ASA physical status 1 to 4, and we excluded those patients who refused to participate or where rapid CPS induction was needed or were not to be received in a neuromuscular blocking drug for securing the airway, like awake intubation, already intubated patient, or tracheostomized patients. So firstly, we identified anticipated difficult mass ventilation in primary pre-anesthetic checkup with bones and Mons criteria. And after taking proper consent in operation theater, a qualified anesthesiologist with at least 1 year experience performed the mass ventilation and marked the best capnographic waveform achieved by using any maneuver or any airway adjuncts before and after administration of the neuromuscular blocking drug. And operator assessment as well choice of the neuromuscular blocking drug was also noted after the mass ventilation. And the baseline saturation, minimum saturation during mass ventilation and after mass ventilation was also noted. So all the data were presented as mean plus minus standard deviation for normally distributed quantitative variable, median for ordinal variables and quantitative variables with non-nominal distribution, and a cross-tabulation table was performed to investigate the sensitivity specificity of different scores that predict the difficult mass ventilation. So we assessed a total of 1,577 patients according to the bones and Mons criteria, and of this 1,222 patients were predicted to have mass ventilation, 355 patients were anticipated to have difficult mass ventilation. All patients subsequently underwent evaluation using a novel capnographic scoring system. Within the predicted easy mass ventilation group, 962 patients were confirmed have easy mass ventilation, and 216 were confirmed as difficult mass ventilation, and 44 very difficult mass ventilation. And in the anticipated difficult mass ventilation group, 30 patients were easy mass ventilation, and 86 patients had a difficult mass ventilation, and 139 patients have very difficult mass ventilation. So coming to the demographic distribution, from this table, you all can appreciate that age, weight, BMI, and ASA status are significantly variable between these two groups, like patients with anticipated easy mass ventilation as well as patients with anticipated difficult mass ventilation. So to evaluate the association between the anticipated and actual difficult mass ventilation, we performed a cross-tabulation of capnographic scoring system and operator assessment with clinically anticipated difficult mass ventilation. From this table, you all can appreciate that if we take score more than 3 as actual difficult mass ventilation according to the capnographic scoring, the sensitivity and the specificity is better than score more than 5, and a similar trend is also observed in difficult and in according to the operator assessment also. If we take difficult and very difficult mass ventilation as actual difficult mass ventilation, the sensitivity and specificity is much more higher than the very difficult mass ventilation. Now, coming to the comparison of the objective capnographic score and operator assessment before and after administration of the neuromuscular blocking drug. Based on the operator assessment, 955 patients were initially identified as having easy mass ventilation prior to the administration of the neuromuscular blocking drugs. This number increased significantly to 1,372 following neuromuscular blocking drug administration. Conversely, the number of patients with difficult and very difficult mass ventilation decreased from 446 to 197 and from 176 to 8 respectively. These improvements were also reflected in the capnographic scoring system also. You can appreciate that, and this ultimately tells that the mass ventilation is much more easier after administration of the neuromuscular blocking drug. So to find out the internal validation of the objective capnographic scoring system, we cross-tabulate it with a subjective operators assessment, where we take score more than 3 according to the capnographic score and according to the operator assessment, difficult and very difficult mass ventilation as actual difficult mass ventilation. This comparison demonstrates that the scoring system achieves excellent sensitivity and specificity both before and after administration of the neuromuscular blocking drug. Coming to the distribution of the patient according to the choice of the neuromuscular blocking drug, in this table, you can see that non-depolarizing neuromuscular blocking drugs were more commonly used than depolarizing agents, and they were associated with great improvement in mass ventilation quality also. And coming to the discussion, age, weight, ASA status, and BMI plays a significant role to anticipate difficult mass. Oliver Langer and Sachin Khetrapal et al. had a similar result in case of age, weight, and BMI, but none of the current studies had examined the association between the difficult mass ventilation and ASA status. Saturation level at different time points was lesser in anticipated difficult mass ventilation group as compared to anticipated easy mass ventilation group. And according to the objective capnographic scoring system, if we take score more than 3 as difficult mass ventilation, it is highly associated with clinically anticipated difficult mass ventilation. And there was significant reduction in the number of difficult mass ventilation after administration of the neuromuscular blocking drug. And there are so many studies which also says that the mass ventilation becomes easier after administration of the neuromuscular blocking drug. And so this further supports the no check ventilation required viewpoint before administration of the neuromuscular blocking drug after induction of the anesthesia. The objective
One more minute,
capnographic
Dr.
scoring.
Jain.
The objective capnographic scoring system is highly validated with the subjective assessment of the difficult mass ventilation before as well as after the administration of the neuromuscular blocking drug. And in our study, non-depolarizing neuromuscular blocking drug, most common choice, even in case of difficult mass ventilation case also. So I conclude myself like that. According to the scoring system, if the score more than 3 is defined as difficult mass ventilation, it is highly associated with the clinically anticipated difficult mass ventilation. And after administration of the neuromuscular blocking drug, the mass ventilation becomes easier than before them. And non-depolarizing neuromuscular blocking drug was a more common choice over depolarizing neuromuscular blocking drug, even in patients with difficult mass ventilation cases also. These are my references. Thank you.
Dr. Roy, my question
Yes.
is, how is the sample size calculated?
Ma'am, it's an observation study, so we do calculate the sample size, ma'am. We took
So what was the time period you had
bound.
taken?
Ma'am,
Yes, what was the time around?
1 year, 1 year, 8 months, ma'am.
1 year, 8 months. Doctor, what is the, you've mentioned the bones and moans.
Yes,
So,
ma'am.
in fact, I think you've written it as MONES in your slide, while it is MOANS.
MOANS, ma'am, sorry.
So, what
Yes,
is
ma'am.
MOANS and what is bones?
Ma'am, bones is bearded individual and obesity, and it also associated with elderly age and as well as the neck circumference also. And in Mohs criteria, that is mast cell issue is there, and obesity, edentulous patients, and that elderly age patients.
What is elderly in this?
Ma'am,
What
age
is
more
the
than
age criteria?
55 years.
Okay, thank you.
Okay, how have you predicted the difficult mass ventilation using bones and moans?
Sir, if in bones and moans criteria, 2 criteria are positive, then it will take as predicted anticipated difficult mass ventilation.
So, for internal validation, is there any other tool that is a considered standard for assessment of difficult mass ventilation?
Sorry, sir.
For assessment of difficult mass ventilation,
Yes,
what
sir.
is the standard tool used?
Sir,
Any
for
other
internal
objective
validation,
tool?
sir, for internal validation, we just calculate the we just create a cross tabulation between the if we take score more than 3, it's it's clinically correlate with the anticipated difficult mass ventilation, and if we take score according to the operator's assessment, difficult and very difficult mass ventilation as difficult mass ventilation. So between them, we cross tabulate this thing, and from this we take the sensitivity and specificity, and from this we can tell that
Did
KT is
you
internally
do an
validated.
ROC analysis of the test? This is a diagnostic test, no?
Yes, sir. Yes. No, sir, that is
Did
not
you do
done.
an ROC analysis of that?
No, sir, that is not done, sir.
So there is no cutoff value that you found out for this diagnostic because you have measured the sensitivity and specificity.
Sir, sir, the previous there study was there. The hand study was there where grade 0 to 4 was there for difficult mass ventilation cases, and where grade 1 is rated as normal mass ventilation, and grade 4 is difficult mass ventilation, sir. no mass ventilation case.
Oh, no, that I understand, but there has to be for RSN, there has to be a cutoff value after which it will actually predict difficult or easy mass ventilation.
No, sir, there is no cutoff value, sir. We took the operator assessment as well as we took the capnographic scoring system, and according to the Nielsen and Lim, there was a grading also, and from this grading we create this scoring system, sir.
So for diagnostic tests like this, what reporting guideline do you follow? Which one did you follow?
Sir, for observational study, we follow the stroke guidelines, sir.
But this is a diagnostic test, no? Assessment. So do you think START should have been followed?
Sorry, sir.
Okay, Dr. Swati, next, please.
I will not be judging him.
Okay, thank you. Thank you, Dr. Jain.
Thank you, sir.
Thank you, Dr. Jain. Moving on to the next presentation, I would like to invite Dr. E. Mahalakshmi. She is working as a senior resident at KEM Mumbai, and she'll be talking on the topic of preemptive ultrasound, gastric ultrasound for emergency lower limb surgery, a preoperative assessment approach. Over to you, Dr. Mahalakshmi.
Yes, sir.
Please share your slide, Mahalakshmi.
Yes, yes, ma'am. I'm trying to share it. Okay. Is it visible?
No, it's not.
No, you've not started sharing it.
You have not started sharing your screen yet.
Okay.
Can you see a green arrow? I mean, green box with a black arrow saying share?
Okay, 1 minute, sir. I'm so sorry, I'm unable to share it.
What issue are you facing? There's a button, you click it on the share button and your screen.
Ma'am, actually,
Are
I'm
you doing
using
it on
a
the phone?
phone. I'm using a phone because I don't have Zoom this thing in my lap. So,
So you can do one thing, please mail your presentation while we move on to the next candidate. Yeah, you please
yes, ma'am.
make late for you. Please mail your
Or
presentation.
Neha, she can send her in that group
Dr.
also.
Neha, Dr.
Yes,
Neha,
sir.
can I say something?
Yes, sir. Please, sir.
Yes, sir, please.
Instructions should be given to the participants that how to use the laptop and what is to be done, how it is to be shared, so that such type of wastage is not there. They should be instructed earlier that how they should present. Make a standard format for how they should present like
Right,
that,
sir.
so that
Right.
these problems do not occur again.
Sure, so we'll make sure that
Thank
next
you.
time we can avoid these glitches. Yeah. So we'll move on to our next presentation, I think, right?
Yes.
So, wait. So I would like to invite Dr. Vaishnavi Singh. She is a junior resident at GSVM Kanpur, and she would be talking on the efficacy of erector spiny plane block for postoperative pain management in lumbar spine surgery. Dr. Vaishnavi, over to you. Dr. Vaishnavi, are you there?
Good evening, sir.
The remaining two presenters, I request in case you have any problem with your presentations, you can please mail us your presentations so that we can avoid any glitches henceforth.
So is it visible?
Yes, yes, just make it full screen.
Good evening, respected faculty member. I'm here to talk about the efficacy of erector spiny plain block in postoperative pain management in lumbar
Dr.
spine
Vaishnavi,
surgery.
can you make it full screen?
Yes, I have made it full screen.
No, you haven't.
It's not. No. Just go on the slideshow or maybe the
Yeah, you're doing, yeah.
Is it okay, sir? I've made
No.
it full screen.
It's not reflecting here. It's still reflecting.
Okay. One.
Close it and start again.
Yes. Yes.
Share it again.
Yeah, share it again.
Yes. Is it visible?
No, it's not. Still not coming as a full screen.
I think let us continue with this only.
Okay, ma'am. Sure. If it's visible to
Let's
you, we can
continue.
continue. Sure.
Yeah, let's continue.
Dr. Vaishnavi,
Sure.
please continue with the presentation.
Okay, thank you, sir. Good evening, respected faculty member. I'm here to talk about the efficacy of erector spiny plain block in postoperative pain management of lumbar spine surgery. This study aimed to evaluate the efficacy and safety of bilateral continuous erector spiny plain block for postoperative pain management in patients undergoing lumbar spine surgery under general anesthesia. As we know that posterior lumbar spine surgery is gold standard for lumbar spinal.
Dr. Vaishnavi, change your slide. I'm still seeing the first slide, Bete. Click on the second slide.
Yes, ma'am. Is it visible, ma'am?
No, we are still on the first slide. Dr. Nitin, can you help her?
Yeah, sure. Can you share your presentation on the WhatsApp group that we have created for you people? We'll just share right away from there.
Yes, sir. Yeah.
Can you just do that quickly so that I can share from my end?
Yes, sir.
In the meanwhile, I have Dr. Mahalakshmi's presentation. Is it visible?
Yes, it is visible.
Dr. Mahalakshmi, you can carry on. You can complete your presentation in the meanwhile.
Yes, ma'am. Good evening to one and all present over here. I'm here to present on my thesis topic, preemptive gastric ultrasound for emergency lower limb surgery, a preoperative assessment approach. It is an prospective observational study. So background and objectives. Gastric aspiration is identified as the leading cause of anesthesia-related deaths. The aim of this study was to observe percentage of population with significant gastric volume, which is more than 1.5 ml per kg. So gastric emptying depends on hours of starvation and comorbidities of the patient. Higher gastric volume incidents are seen in pre-existing diseases. Methods. After an ethical approval and informed consent from the patient, a prospective observational study, which included 155 patients requiring an emergency lower limb surgeries. Gastric volume was assessed using two diameters, both in supine and right-rated decubitus position. Using a Perlas formula, volume was calculated. First, both the cross-sectional area was calculated using two diameters, and then which was substituted in Perlas formula. So volume equals to 27 plus 14.6 into cross-sectional area minus 1.28 into age in years was calculated. This was done after before taking the patient inside the OT in the preoperative room. A quick assessment of gastric ultrasound was done, and then patient was taken inside the OT. The inclusion and exclusion criteria for my study is inclusion criteria are age from 18 to 65 years on both the genders, and patient undergoing emergency lower limb surgery with ASA grade between 1 to 3. And the exclusion criteria, patient will not willing to participate, any pregnant patient or patient with any nasogastric tube in situ, and patient who are unable to lie on right lateral position, patient with poor echo window. And this is the image which shows, the first image shows the bullseye appearance, which is seen in supine and right lateral position, and which signifies the low pulmonary aspiration risk. This is an empty stomach. And the middle image, which shows a fluid content and a hypoechoic image, which also signifies the lower pulmonary aspiration risk, which is also called grade 1 and grade, which is divided into grade 1 and grade 2. In grade 2, where this hypoechoic structure is seen both in right lateral and the supine position. And the last image shows the frosted glass appearance, where hyperechoic consistency is seen, which signifies there is a solid particle and signifies the high aspiration risk. Results, out of 155 participants, 6.5% had a significant gastric volume in the supine position and 1.9% in the right lateral position. Longer fasting reduced gastric volume significantly in supine, but not in the right lateral position. The participants with diabetes alone have a slightly higher mean gastric volumes than those with other comorbidities or none, but the differences are statistically insignificant. So, discussion in emergency surgery, ultrasound assesses gastric volume in both starving and non-starving patients with comorbidities related to slower gastric emptying. In our study, we observed the participants who have diabetes alone show a slight higher mean gastric volume compared to those with none. So Garima Sharma et al. Study concluded that longer fasting hours does not ensure safer gastric volume. Conclusion, a study concluded that the gastric volume should be assessed for all emergency surgeries. This will help to reduce the risk of gastric aspiration, to improve individualized care and possibly impact patient safety. Thank you.
Over to you, judges.
Dr. Mahalakshmi, I want to know
Yes, ma'am.
what was the measurement of anteroposterior and the craniocaudal diameters of the gastric antrum which was done?
Ma'am, it differs from patient to patient. Some patient, that if the patients are very thin built, their anteroposterior diameter comes around 1.9 centimeter. If some patients are like obese patients, then their anteroposterior diameter comes around 3 centimeters. So, according to that, we measured the anteroposterior diameter of craniocaudally, and this from both the sides we calculate the diameter, two diameters, then substituted in a cross-sectional area formula, and then we found the cross-sectional area of the area in the supine position. Then we have substituted that value in the Perlas formula.
Was any prokinetic administered in any of the patients?
Ma'am,
and what was the last meal which was partaken?
Ma'am,
The duration of the last
actually,
meal?
ma'am, we have not administered any prokinetic formulas, since we have not included any medication in our studies. We just want to observe the gastric volume for the patients who are posted for emergency lower limb, and the starvation depends on the how emergency the case is taken, ma'am. So
Was
we
there
have
any difference between the male patients and the female patients?
no, ma'am, there was no any difference.
Okay, thank you.
Thank you.
Yes, thank you. Why did you choose lower limb orthopedic patients?
Sir, This actually it was solely based on my principal investigator, my guide. So we chose because this study was not done on any emergency cases, but there are studies which is done on other elective surgeries. Since if we have taken lower limb patients because patients will not have any difficulty in lying down supine or right lateral. But if it is a case of explorative laparotomy, then there is a difficulty in patient to lie right lateral position. That's why we chose lower limb surgery cases.
But there may be more difficulty in the orthopedic patients lying in the right lateral position. In any case, this gastric ultrasound is best performed in the right lateral. Why did you use a
Yes,
supine
sir.
limb?
Sir, it based on the parent study, I chose both the positions, sir, to just compare between not to compare and observe the volume.
At what level did you measure the gastric volume? Was it at the inferior vena cava?
Sir, in the sir, what level? In the epigastric region, first I try to visualize the liver. Then using a curvilinear probe, first I visualize the liver. Then slowly bring it to the center. Then I can after visualizing the superior mesenteric artery, then I'll try to locate the antrum of the stomach, which is most dependent part in the stomach. So antrum is more visible than other parts.
Okay, yeah, because gastric ultrasound volume assessment, especially using the Perla's formula, is quite deficient at various places, especially the inferior vena cava. So you probably have measured at the SVC level.
Sorry, sir. Sorry, sir. I didn't.
Yeah, Dr. Swati.
Yes, sir.
Yes,
No
Dr.
problem.
Mahalakshmi, in the extension to Dr. The previous question,
Yes,
if a
ma'am.
patient, because you have taken lower limb surgeries, if you're
Yes,
not
ma'am.
able to turn the patient right lateral decubitus, did you
Yes,
exclude
ma'am.
them or did you take them in some other position?
Ma'am, actually, I didn't experience any such like they couldn't turn to right side. They were convinced and they were comfortable in turning right side. Then only I had taken the measurements, ma'am.
Even if they had any right-sided bone fractures or anything?
No, ma'am, no, not nothing like that. Usually, I preferred a left side limb surgeries. Most of my patients are on left sides only. Right side, any BK is posted, then we used to take. But as such, my patients are not did not experience any uncomfortable. So I didn't
Okay.
experience.
Can you tell some other formulas for gastric volume assessment with ultrasound except for Perla's formula?
Sorry, ma'am. Not.
Okay, never mind. And what other is the Perla's formula validated for all the age groups and even for obese patients? What BMI is okay with Perla's formula?
Ma'am, since ma'am, there is no BMI restriction for Perla's formula. So, even the obese patients, BMI more than 30 was also calculated using Perla's formula.
Okay, you said diabetes alone was some had more gastric volume. Can you
Yes, ma'am.
tell other factors for delayed gastric emptying?
Yes, ma'am. There are other comorbidities like obesity, CKD, and then obesity, CKD, ma'am. Obesity and CKD patients and diabetes mellitus patients, where they have delayed gastric emptying.
Any other specific patient population?
Ma'am, pregnant patient is also there, but those groups are not, those group was not included in my study.
Oh, no, I'm not asking about your study, but in general.
But yes, ma'am, pregnant patients.
And some medications?
Ma'am, medications with any um, uh, potassium group. Those things are actually delay gastric emptying, ma'am.
Okay, right. Thank you.
Thank you.
Thank you, Mahalakshmi.
Thank you, sir.
So we'll move on to the next presentation by Dr. Vaishnavi. The presentation is here. Dr. Vaishnavi, you can start. I'll just move on your slides. Are you there?
Yes, sir. Good evening, sir.
Yeah, please continue with the presentation.
Good morning, respected faculty members. I'm here to talk about efficacy of erector spinal pain block in post-operative pain management of lumbar spine surgery. The study aimed to evaluate the efficacy and safety of bilateral continuous erector spinal pain block for post-operative pain management in patients undergoing lumbar spine surgery under general anesthesia. As we know that posterior lumbar spine surgery gold standard this gold standard for lumbar spinal diseases. Ineffective post-op pain management leads to decline in the patient's activity, increased incidence of various complications such as deep vein thrombosis, pulmonary embolism, and pulmonary infection. Facial pain blocks manage perioperative pain and treatment of chronic pain. One of the newest techniques is rectal spinal pain block. This study functions by local anesthetic diffusion and radiolumbar fracture, which blocks the dorsal and ventral branches of spinal nerves in the corresponding areas and alleviates nociceptive pain and visceral pain at the same time. Aims and objectives. Primary objective of this study was to assess the efficacy of erector spinal pain block for post-op pain management of lumbar spine surgery. Secondary objective was to assess the efficacy of erector spinal pain block to assess the safety of erector spinal pain block for post-op pain management of lumbar spine surgery. Material and methods. The study was prospective. The one at GSVM Medical College, Kanpur. The duration of the study was 2 years. Inclusion criteria was informed written consent for participation in study. Patient aged 18 to 65 years belonging to ASL clinical status 1 and 2 and patients undergoing lumbar spine surgery under general anesthesia. Those excluded were patients below 18 years of age, pregnant females, known allergy to local anesthetics, or any coagulation disorders. In a prospective randomized triple-blinded clinical trial, 70 adult patients of ASL class 1 2 scheduled for lumbar spine surgery were divided into two groups of 35 each. The control group received standard general anesthesia without regional block, while the ESPD group received bilateral continuous ESP block with 25% Propivacaine in addition to standard care. Post-operative pain intensity was assessed using the visual analog scale at rest and during movement at regular intervals. The time to first cluster analgesia, total fentanyl consumption in the first 24 hours, and any block-related or opioid-related complications were recorded. Here we can see the catheter, and the catheter was introduced intraoperatively prior to closure of the surgical site. So we have the post-operative X-ray. Then the picture B is before insertion of the catheter. Then picture C is after insertion of the catheter and the completion of surgery. Results. Compared to the control group, ESPD group had significantly lower VAS scores at all measured post-operative time points which was statistically significant both at rest and during movement. The time to first rescue analgesia was markedly prolonged in the ESPB group, which was 12.83 plus minus 0.88 hours versus 3.89 plus minus 0.65 hours in the control group. When total 24-hour fentanyl consumption was substantially reduced. That is 151 plus minus 16.62 microgram versus 393.57 plus minus 49.01 microgram, which was statistically significant. No major complications or adverse effects related to the drug were observed. We have also recorded the hemodynamic stability at excavation, which we can see that heart rate, mean arterial pressure, and respiratory rate were more stable on the patient receiving directed spinal fluid block compared to the control group. Now we have bar chart showing visual analog score at rest and movement at 1, 2, 4, 6, 12, and 24 hours. We can say that these scores at movement have lower in the recklessly pain that compared to standard analgesia. Similarly, VAS scores at rest are also lower in PSPB group compared to standard analgesia group. Time to first rescue analgesia around 12.2 hours in ASPB group compared to 3 to 4 hours in PSPB group. Even 24-hour fentanyl consumption was lower in the ESPB group, which was around 150 microgram compared to 394 microgram in case of standard analgesia group. Time to first ambulation was around 12.4 hours in ESPB group compared to 15.1 hours in control group. Even length of hospital stay was reduced in the patients receiving electrospinal pain block, which was around 5.6 days compared to 7.2 days for spinal control group. We also noted the incidence of post-op nausea and vomiting, which was around 10% in electrospinal pain block group compared to standard analgesia group, where the incidence was around 28%. 23%.
One more to you, Dr. Vaishnavi. Please carry on.
Yeah.
Please complete
Yes.
first.
Yes, ma'am. Overall patient satisfaction score on a scale of 1 to 4 was higher in ESPB group compared to standard analgesia group. To conclude, bilateral ESPB provides safe and effective post-operative analgesia for lumbar spine surgery. It significantly improves pain control and reduces opioid requirements, supporting its role as a valuable component of multimodal analgesia for lumbar spine surgery. Thank you.
Good presentation, Dr. Vaishnavi. My question is, what do you mean by a triple blind? What is the difference between single blind, double blind, and a triple blind study?
Ma'am, in single blinded study, the patient that is receiving the intervention is blinded. In double blinded study, the patient that is receiving the intervention as well as the person, the doctor who is reproducing the intervention, both are blinded. In triple blinded study, the doctor providing the intervention as well as the data panelist, all three are blinded.
Did you measure what is static and dynamic pain? And how do you measure it?
Ma'am, for static pain, we measured while patient was lying comfortably supine in his bed. And for dynamic pain, we looked at patient while they were making general movements in the bed only.
Dynamic pain, basically, it is after 6 hours that you assess the pain and the patient is log rolled. And once
Yes.
the patient is log rolled, then you assess the pain. What is the intensity of pain? So what are the scales which can be used to assess the pain?
Ma'am, one is visual analog scale. Other than that, we have RAS scale, then we have Megger scale, these three, and then we have these three scales now.
To my over to my co-judges.
Yes. At what level do you place the catheters for this surgery?
So in this surgery, what we do that because in spine surgeries, if one level is to be operated, the incision is made one level up and one level down in the spinal segment. So comparatively, from the topmost point of the incision, 3 centimeter lateral to that is our most supine point of insertion of catheter.
So how much resistance did you face from the surgeons for this kind of analgesia, given that they are very particular about sterility?
Yes, so I think closer at the surgical site, even I was then properly surgically draped, and that is how I performed. I scrubbed like the surgeons do.
Do you recommend this on a routine basis for all surgeries?
So, yes, my experience says that it should be recommended.
Dr. Swati.
Yes, thank you. Dr. Vaishnavi, what is the purpose of randomization in an interventional study?
Ma'am, the purpose of randomization in surgery is to remove the bias. And so we are preferentially giving the treatment to one particular group of patients, so that our study is not biased and its validity is there.
Okay, and what is the purpose of blinding?
Ma'am, blinding is done to remove bias.
Both are for bias. Both are for removing the bias, randomization as well as blinding. Okay, what are the type of bias which can occur in an randomized control trial?
Ma'am, it can be the it can be in. Sorry,
Okay,
ma'am.
never mind. And what is the meaning of controlled? You say na RCT, randomized controlled trial. Why is it called controlled?
Ma'am, because in this we divide the divide our subjects into groups, and then we
You said na that you will give a particular fentanyl or you'll give. So you're controlling the things, right?
Yes, ma'am. Yes, ma'am.
You are not allowing the anesthetist to do anything they want to. So
Yes,
that's
ma'am.
why. Okay, right, never mind. Thank you.
Thank you, ma'am.
Dr. Nitin, you're mute, I think.
Okay, yeah. So next we have Dr. Shrishti. She's working as a junior resident at AIIMS Guwahati, and her topic of study is assessment of the functional outcome of intra-articular steroid injection for knee osteoarthritis in non-diabetics and controlled diabetics, and interim analysis of the observational data. Over to you, Dr. Shrishti.
Good evening, everyone. I'm going to present an interim analysis of my thesis topic, that is assessment of the functional outcome of intra-articular steroid injection for knee osteoarthritis in non-diabetics and controlled diabetics. Introduction. As we know that there is an increased incidence of osteoarthritis with advancing age and the acceptance of Western lifestyle with the use of Western toilets, eating and lifestyle habits,
and the prevailing obesity and comorbidities, the incidence of knee osteoarthritis in India has increased to about 22 to 39%. As per the standard treatment recommendations, intra-articular steroid injection is practiced widely and is recommended as one of the modalities in the management of knee osteoarthritis, but with variable results. This variability could be due to heterogeneity in the patient population, severity of osteoarthritis, type and dose of steroids, and the injection technique. Though intra-articular steroid injection is a routine practice in the management of knee osteoarthritis, its outcome in diabetic and non-diabetic has never been evaluated to the best of our knowledge. That is why we are undertaking this study to compare the outcome of ISI for knee osteoarthritis in non-diabetics and controlled diabetics. Based on the findings and previous studies, there is a potential link between diabetes mellitus and the worsening symptoms and severity of osteoarthritis. Moreover, the intra-articular steroid injection is associated with transient hyperglycemia, which can lead to increased risk of infections and advanced degradation because of the metabolic dysfunction which is observed in diabetes mellitus. The aim of my study is to analyze the functional outcome following intra-articular steroid injection at 2 weeks and 4 weeks in knee osteoarthritis in non-diabetics and controlled diabetics. The objectives are, the primary objective is to observe the functional outcome following ISI at 2 weeks and 4 weeks in knee osteoarthritis in non-diabetics and controlled diabetics as evaluated by the Western Ontario and McMaster University's Arthritis Index, abbreviated as WOMAC, and Numeric Rating Scale, abbreviated as NRS. Secondary objectives are to observe the CRP levels at 2 weeks and 4 weeks in each group, to quantify the dose of rescue analgesic that were required in this interval, which were taken at 2 weeks and 4 weeks in each group, and to observe any local or systemic complications at 2 weeks and 4 weeks in each group. Methodology, the study design, it is an observational study wherein the patients were enrolled from the outpatient clinics of Pain Medicine and Orthopedics Department, AIIMS Hospital, Guwahati. The total sample size is 86, where 43 were in each group, and as of till date, 50 patients were enrolled, or 26 are in non-diabetic group and 24 in controlled diabetic group. The study period is of 1.5 years, and we started enrolling the patient after the trial was registered prospectively in CTRI on 1st August 2024. We were calling the patients at 2 weeks and 4 weeks, so the follow-up was of 4 weeks. Inclusion criteria: individuals non-diabetic and controlled diabetic of more than equal to 45 years of age with unilateral or bilateral symptomatic knee pain of NRS more than equal to 4/10 on most days for the past 1 month and radiologically confirmed knee osteoarthritis with Kellgren-Lawrence radiographic severity of grade 2 to 3. The exclusion criteria were refusal to consent, patients with or without diabetes having HbA1c of more than 7% at baseline, ISI in the past 3 months, history of any systemic inflammatory arthritis, history of trauma, surgery, or infection in the affected knee joint, overlying skin and soft tissue infection, uncontrolled bleeding diathesis, known case of cancer, clinically significant cognitive impairment, and known allergy to triamcinolone acetonide or lignocaine. This is the chart. Here, patients were recruited and the consent taken. Baseline CRP, HbA1c, WOMAC, and NRS were recorded. In group non-diabetic, till date, 26 participants have been enrolled, and controlled diabetic, till date, 24 participants have been enrolled. After skin testing with lignocaine, ultrasound-guided intra-articular steroid injection of triamcinolone acetonide, 40 mg plus 2 ml of 2% lignocaine were injected. Then the patients were called at 2 weeks and 4 weeks, and the functional outcome was assessed by WOMAC and NRS. The CRP levels were recorded, any rescue analgesics which were required in this interval or any complications that occurred were recorded. Data collection and analysis was done. Here we can see the interim analysis. Here the WOMAC score was statistically significant as the p-value was 0.02 and it was less at 2 weeks. However, we can see that the other values were not statistically significant. So the 24 patients which were controlled diabetic and the 26 patients which were non-diabetic, the median Kellgren-Lawrence rating was 3 and the reduction in WOMAC score at 2 weeks was significantly higher in the controlled diabetic than the non-diabetic patients. But this difference was not noted at 4 weeks. There was no difference in the change in CRP and NRS score, and from baseline to 2 weeks and 4 weeks between the two groups, and no difference was noted in the rescue analgesic requirement between the two groups. Discussion. The reduction in WOMAC score at 2 weeks was higher in controlled diabetic than non-diabetic due to low-grade inflammation in controlled diabetics, and the steroids may have pronounced effect in reducing this inflammation, leading to a greater improvement in the symptoms, which was reflected in the WOMAC score also. Intraarticular steroid injection may work more effectively in diabetics by modulating the immune response significantly. Limitation with the collected sample, it is, however, too soon to come to a conclusion. So the conclusion of this is that controlled diabetic had a higher reduction in WOMAC score after AHISA at 2 weeks than the non-diabetic population. However, the difference did not persisted up to 4 weeks, and no other differences were noted for other scores, other parameters such as C-reactive protein reduction, pain score, and the requirement of analgesia. These are my references. Thank you.
Thank you, Dr. Srishti. What is the experience of the person who's performed the blocks? And were all the blocks performed by the same person?
Yes, sir. Yes, ma'am. All the blocks were performed by the same person, and the blocks were performed by our sir, and I only took the data from the patient and have followed up at 2 weeks and 4 weeks.
What was the duration of diabetes in your diabetic controlled
Ma'am,
diabetes patients?
it varied. Some participants had like been diabetic about 5 months, and some were even like 4 to 5 years also. The duration of diabetes is varying in my till date collected data, sir, ma'am.
Okay. Thank you so much.
Dr. Shrishti, you
Yes,
had a
yes, sir.
significant difference in the WOMAC score, but the pain
Yes, sir.
scores were not significant. So
Yes,
don't
sir.
you think, why do you think there is this difference? The stiffness and the functional evaluation could be because of non-steroid reasons.
Sir, sorry, sir.
Why is there a difference when there is no difference in the pain? Why is there a difference in the WOMAC score?
Sir, in WOMAC score, we are taking 3 domains: pain, stiffness, and the physical function. So, although the pain parameter was, as we calculate the pain parameter via the NRS, there was no difference. But the other two domains, that is stiffness and physical function, was improved, and it was better seen in the controlled diabetic population, sir. The other
So
two
do you think?
domains may have.
Yeah, sorry.
Yes, sir.
Continue. The other two domains?
So according to me, the other two domains were enhanced. That's why I could get a significant reduction in the WOMAC score, sir.
So do you feel the steroids improve the stiffness also, and how?
Sir, steroids, we know that in osteoarthritis there is inflammation, and the continued inflammation will be improved by the steroids.
There can be a problem. There can be an influence of physiotherapy also. The movement, all these things matter for stiffness.
Sir,
The other thing
for
is, why
that,
did you measure the CRP? CRP.
sir, CRP was for quantitative assessment, and sir, for all the patients after giving the steroid injection, we had prescribed, we had asked all of our patients to follow up with the exercise. Some exercises were taught to all of the patients.
No, but why CRP? That is a systemic inflammation indicator of systemic inflammation. This mediates a local anti-inflammatory effect, intra-articular steroid. So do you think there would have been a difference in both the patients?
In some other studies, while I was preparing for my thesis protocol, in some studies I have observed that they have also taken the CRP levels. So I also included it as it will be better quantitative evidence for my study.
Okay, Dr. Swati.
Yes, thank you. Nicely presented, Dr. Srishti. My question to you is, what was your research question?
Ma'am, according to my research question and my hypothesis, I had predicted in the start that there will be better functional outcome in the non-diabetics individual after intra-articular steroid injection.
And okay, why do you think, can you justify your study design with your research question?
Ma'am, here population we have taken the non-diabetics and controlled diabetics. The intervention was intra-articular steroid injection, and the outcome was of the functional assessment via the WOMAC and the NRS score. So here, I have first, as per the previous studies, we know that diabetes mellitus is associated with advanced glycation end products and other mediators which may further impair the joint function. But also here in my study till date, what I have observed is the diabetic individuals must have a high threshold for pain. And with steroid injection, I have observed a significant reduction in their complaints for the pain.
Why would they have higher threshold for pain? Or there'll be reduced sensitivity to pain or something like that. Neuropathy, you want to say?
No, none of the patients had developed neuropathy when I had enrolled, but yes, there was a high threshold to pain because initially also when they came, their NRS was higher than the other patients, but still after following injection, I used to call up my patients and there was no, they had improvement.
Okay. So, what are the limitations of an observational study?
Ma'am, observational study, here we obviously have this viewer bias. Then other than that, here in my follow-up study, attrition bias is there. Other than that,
Okay, which studies are at the have the highest evidence? They provide the strongest evidence when we are looking at the evidence pyramid.
yes, no, observational study lies at very extreme bottom. But since in my institute, when I was
I am
preparing my
asking you
thesis,
which is at the highest. I'm not
which
criticizing
is
your
at the
study.
highest, ma'am, systematic reviews
Okay,
and
very good.
meta-analysis.
Yeah, thank you.
Yes, ma'am. Thank you, ma'am.
Thank you, Dr. Srishti. So
Thank
we'll
you.
move on to the last presentation for the day. So I have Dr. Ruchi Goel with us. She's a junior resident at MAMC, New Delhi, and she'll be presenting her topic on comparative evaluation of quadratus lumborum versus subcostal transverse abdominis block in laparoscopic cholecystectomy for postoperative anesthesia. Over to you, Dr. Ruchi.
Thank you, sir. Is it visible?
No, it's not.
Okay,
Can you see the
yes,
share
I'm
button
just
in the?
ready. Yes.
Yeah. Good. You're
Is it
sharing it.
visible? Yes,
Yes.
yes.
Let's just make it full screen. Yeah, you're good to go. Yeah. Please start.
Yes, sir. I'm not able to see my presentation. Just a minute, yes. Okay. Good evening, everyone. I'll be presenting my research topic, comparative evaluation of quadratus lumborum versus subcostal transverse abdominis block in laparoscopic cholecystectomy for postoperative analgesia. So, as we all know, that despite recent advancements in surgical technique, anesthesia management, the management of postoperative pain remains a crucial challenge. Uncontrolled pain can lead to delayed recovery, prolonged hospital stays, and subsequently heightened costs of healthcare. In laparoscopic cholecystectomy, the postoperative pain is composite of three distinct components, which is the incisional pain due to trocar insertion site, visceral pain due to which is originating deep within the abdomen, and the referred pain. To provide optimum analgesia in abdominal surgeries, regional anesthesia techniques such as QL block and subcostal transverse abdominis plane block have gained increasing popularity. So the aim of my study was to perform a comparative evaluation of quadratus lumborum versus subcostal transverse abdominis block in laparoscopic cholecystectomy with respect to first postoperative rescue analgesia. Sample size was calculated based on pilot cases and using the formula and the sample size, taking an attrition rate of 10%, the minimal sample size calculated was 40 in each group. It was a randomized comparative study performed over a period of 12 months with a power of 80% and alpha error of 5%. Inclusion criteria were ASC grade 1 and 2 patients, and age limit was 18 to 60 years. Exclusion criteria was patient refusal, BMI more than 30, a local site infection, pre-existing coagulopathy, allergy to the medication, study medications, and inability to understand the numerical rating scale. And the patients were randomized into two groups, group QL, which is the quadratus lumborum block group, and group TAP, which is the subcostal transverse abdominis plane block. All the patients underwent general anesthesia. Following induction, both groups received the respective regional block procedure. Prepared solution of 0.3 ml per kg of 0.25% bupivacaine was bilaterally injected at the designated block site. Conventional 4-port laparoscopic cholecystectomy with normal pressure CO2 pneumoperitoneum was performed. The patient was shifted to PACU, and pain scores and patient satisfaction scores, block-related complications were noted. This is how I performed the quadratus lumborum block. Patient was placed in lateral decipitous position. USG probe was curvilinear USG probe was used, and it was placed in the anterior axillary line at the level of umbilicus, and then it was advanced posterior. And the QL muscle was visualized, and a prepaid solution of 0.3 ml per kg of 0.25% bupivacaine was administered bilaterally. And similarly, for TAP block, the patient was positioned in supine position, and rectus abdominis muscle was identified. And at the junction where we can visualize the rectus abdominis muscle above and the transverse abdominis muscle below, at that junction, the same volume of bupivacaine was administered bilaterally. So my primary outcome was to determine the time for first rescue analgesia, which was determined as a time interval when the patient was immediately shifted to post-op to the time when the patient experienced a numerical rating score of more than 3. And the other outcomes that were measured were post-operative NRS score at 0 hour, first, second, 4, 6, 12, and 24 hour. Total analgesic consumption at 24 hour post-operatively. Hemodynamic changes which were recorded intraoperatively at various time intervals. Patient satisfaction score at 24 hours and any block-related complications. These tests were used, SPSS 25 was used as a statistical software, and p-value of less than 0.05 was considered statistically significant. Sharing the results, the time for first rescue analgesia was significantly higher in QL group with a p-value of less than 0.01. Similarly, total paracetamol requirement, total tramadol requirement, and post-operative satisfaction scores were also statistically significant, saying that they were better in QL group. NRS score was only significant at 6 hours and 24 hours post-operatively. This is the graphical representation of the same. In the graph on the left side, we can see that the NRS score are significant at 6 hours and 24 hours. And on the graphs on the right side, we can see the total analgesic consumption of paracetamol and tramadol respectively, showing that the patients with in group TAP had higher requirement of both paracetamol and tramadol as compared to the QL group. So the time for first rescue, the time for post-operative request for first rescue analgesia was significantly longer in QL group compared to the TAP group. And a recent study by Yoshima et al. also support my study. The total analgesic requirement in the first 24 hours was also was significantly higher in TAB group, and a meta-analysis by Liu et al. Was also depicting the similar results. There was no significant difference in the pain scores between the two groups at 0, 1, 2, 4, and 12 hours. However, 6 and 24 hours were significant. This suggests that both the blocks are viable option for pain management in the patients undergoing laparoscopic cholecystectomy. Patient satisfaction score at 24 hours was significantly different, meaning that the patients receiving QL block had better patient satisfaction scores compared to the TAB group. And there were no hemodynamic changes, difference in the both the groups, and no block-related complications were noted. To conclude, the QL block exhibit superior analgesic efficacy characterized by prolonged time of first rescue analgesia and higher patient satisfaction scores compared to the subcostal TAB group. Given its potential to improve the patient recovery and opioid consumption, the QL block represents a valuable option for optimizing pain management in laparoscopic cholecystectomy and warrants further investigations in larger multicentric trials. Limitations: it was a single center study and number of patients that were enrolled in the study were less. These are my references. Thank you.
Thank you so much, Dr. Ruchi. My question to you is that what is the difference between which is a better drug, bupivacaine or ropivacaine?
Ma'am, bupivacaine is better. But in regional blocks, we can use both the drugs, as ropivacaine is essentially different because of its motor efficacy. It has the motor blockade is less as compared to bupivacaine, and it is more cardio. It is safer compared to bupivacaine.
And how did you reach that this concentration of 0.25% should be used? Because most of the studies that I've seen, they've used either 0.5% or 0.375%.
Ma'am, in various studies that the primary studies that I have taken, and 0.25% bupivacaine was used, and as I was targeting the sensory element of the nerves, I wanted to compare the pain. That is why I used 0.25% concentration.
Okay, thank you.
Thank you, ma'am.
Thank you, Dr. Ruchi. I have slight concerns with the statistics that you have used. For measurement of pain at different time points, you have used the Mann-Whitney U-test. Is that correct?
Yes, sir.
Can you justify that? It is a repeated measurement. You have measured it at different time points.
So yes.
Tell me.
So I have used first I have used numerical rating scale to compare the pain in both the groups, and I have applied Mann-Whitney U-test because it's a non-parametric test, because the values were not falling into the normal distribution. That is why I had to go for a non-parametric test, and the p-value were determined separately for each NRS.
This is a repeated measures. The pain score. You used NRS at different time points. It has to be a repeated measure. If it was parametric, you could have gone for a repeated sequence ANOVA. For a non-parametric, for this, if it is not normally distributed, you could have gone for a Friedman. So that statistics part, I am a little concerned, because that changes a lot of the p-values and the decisions.
I have used it because the values were different in both the groups. So it was not following the normal distribution. That is why, with the help of the statistician
The other
as
thing
well.
is that you have measured the patient satisfaction score.
Yes, sir.
How did you measure that? Was it that based on a Likert scale or a
Yes,
numerical rating?
yes, sir. It was a 7-point Likert scale. I used it based on extremely dissatisfied to extremely satisfied, from grading from 1 to 7.
Okay, so when you have used the patient satisfaction score, have you also assessed their education level or something? Because many times these satisfaction scores are more of a relief score, that the surgery has gone well. their level of education there that needs to also be assessed when you are doing a satisfaction assessment.
Yes, sir, I understand that it was a subjective parameter, but then all of these parameters were explained to the patient in the preoperative period, and their understanding was taken into account of whether we should enroll this patient into the study or not.
Okay, and finally, laparoscopic cholecystectomy, how much is normally the pain post-operatively? Do you think it is troublesome enough to warrant a bilateral QL block?
So my study was basically an extension of knowing, because the more and more surgeries are now conducted laparoscopically. Even laparoscopic cholecystectomy, I will not say it is a moderate surgery, but high risk surgeries and colectomies are also now being performed laparoscopically. So my study was in conjecture with the ERAS protocol, and I wanted to choose a patient group in which I can have more number of patients, and laparoscopy physiology more or less remains the same. And although conventionally the pain due to laparoscopic cholecystectomy has been managed with the NSAIDs, basically multimodal analgesia, more towards the NSAIDs part, IV analgesics, but since we are moving towards ERAS, and uh, now I've seen that more patients are going for laparoscopic surgery. So maybe my research can be extended into different surgeries which are not which have more pain than
But unfortunately, Dr. Ruchi, you can just conclude based on the patient population that you've suggested. Hai na?
Yes, sir.
You may or may not be extrapolated to other surgeries. Dr. Swati, please.
Yes, thank you, Dr. Nisha. Dr. Ruchi, my question to you is whether you are aware of QL1, 2, and 3 blocks,
Yes,
and
ma'am.
which one did you use?
Ma'am, I used QL2, which is the posterior quadratus lumborum block. In this, we deposit the drug between the quadratus lumborum muscle and the middle thoracolumbar fascia. However, there is QL1 and QL3 as well. QL1 is the lateral QL block, in which we deposit the drug between the posterior thoracolumbar fascia and the QL muscle, and QL3 is the intramuscular QL block, in which we go more deeper and we pierce the anterior thoracolumbar fascia.
Okay, what was the status of blinding in your study?
Ma'am, it was a double-blinded study, meaning that the patient and the assessor of the pain in the postoperative period was blinded.
Okay, and how was the patient blinded? He was the patient was under GA, right?
Yes, ma'am.
And what is the difference between subcostal tap and the regular tap which you have?
Ma'am, in subcostal tap block, we deposit the drug between the we scan and we find out where the rectus abdominis muscle is, and then we take the probe a little lateral to a point where the abdominal muscles are originating, the external oblique, internal oblique, and the transverse abdominis. So we essentially deposit the drug just below the rectus abdominis and between the rectus abdominis and the transverse abdominis muscle. However, in conventional tap block, we deposit the drug between the internal oblique and the transverse abdominis muscle.
So you gave bilateral subcostal and bilateral QL in all the patients
Yes,
in
yes,
respective
ma'am.
groups.
Yes, ma'am.
And what position for QL block?
Ma'am, in lateral decubitus position, lateral.
Did you note the time taken to give the blocks?
No, ma'am.
Okay, thank you.
Thank you, ma'am.
Thank you. So with this, we come to the end of today's session. I thank all the presenters for their wonderful scientific compilations which they have shared with us. I request the judges if they have any takeaway messages for our young budding anesthesiologists, new researchers who are in line. Maybe that would be fruitful for them before we wind up, and I ask Dr. Tanveer for a vote of thanks. Anything from, yeah.
From my side, I would like to say that most of the presentations were not according to the guidelines with which the slides should be prepared. Actually, your slide presentation is a part of your, marking scheme. So there are certain guidelines when you're presenting or making your slides that the lines should be around 6 lines, not more than 6 lines should be there. Each line should not have more than 6 words. So we had a lot of people who had put a lot of data, lot of text in this, and that takes away the attention from the core message they want to convey. Secondly, please do not use caps lock for the whole sentence. It has to be used as a sentence case. And then the color combinations and all that has to be worked out. If you're using light color in the background, the darker color should be used. Do not use red, green, and yellow colors in your slides. So that was one part which I found was missing in a few things. And when you're presenting, make it more pictorial. Otherwise, the data and everything was very nice. If you can insert a video, that is much better. And high-speed video can also be inserted for your material and methods.
Thank you,
That's
ma'am,
all.
for your
Otherwise, we had
inputs.
good presentations from everyone.
Yes, thank you. And more or less, the presentations were really nice. Actually, these young generation people, they've actually presented quite well. They've done their studies also quite meticulously. A couple of things, and most of them have actually stuck to time. But this is one thing that I tell all the presenters, that time is very important. And thankfully, in this presentation, everybody has stuck to time. I think those are the things that I would like to inform. Yeah.
Thank you, sir. Swati ma'am.
Yeah, excellent studies, and the way they presented all of them was extremely good. As Dr. Nishant has said, they really stuck to time, and we seniors must, learn from them how to stick to time. So that's a good takeaway for all of us. Regarding studies, I think they should, many of them mentioned that, okay, our guides asked us to do so. Please put up questions to your guides. Why are we choosing this particular study type for the research question we have? Because any study starts with a research question. So why observational study for this particular research question and not a randomized control trial? Please keep on asking questions to your guides. Just don't keep on following blindly, okay? Trust them that they are doing the right thing, but ask questions, because that is a learning process. Just don't do whatever they say we have done like that. So please take a inquisitive overlook to that. And that's it. That's my 2 cents on this. Thank you so much.
Thank you. I thank the judges and the presenters once again. As far as the result is concerned, since we have 3 judges and we'll be compiling the results of all the 3 judges,
Dr.
so it's
Nitin,
going to take. Yeah,
sorry to interrupt you. We can have a few words from call sir as well.
Yes, yes, please, sir. Please, sir.
Yeah.
I must congratulate all the speakers. They presented it very nicely in time. However, there should be a complete instructions to the presenters for the presentation, that how they should present, how they should use, they should stick to the time. All of them did stick time. And I also appreciate all the 3 judges, Dr. Parul, Dr. Swati, Dr. Nishant. In spite of the fact that instead of 1.5 hours, it has taken almost 3 hours, the judges kept their cool, were very judicious in asking the questions of the same level and for the same duration for all the speakers. I was highly impressed when even the last speaker, they did not hesitate to put the equal number of questions and for the equal time. Hats off to both the speakers as well as the judges and the organizers. Thank you very much. God bless you all.
Thank you, sir. Thank you, sir. We'll make sure, sir, the glitches that we had in this session, we don't have in subsequent sessions. We have taken a note of that, and I'm sure we'll not disappoint you the next time we hold the session.
Thank you. Thank you. Thank you. Thank you. No, it is not about disappointment. It is about learning. This has to be this is the Yuva group. They need to be taught. They need to be explained that how things should be done. So this is all a learning process for both the presenter as well as the judges, the teachers, the observers, everybody. Even for me, I learn a lot. I don't know how much others learn. I learn much, much more than everybody. I learn quite a lot because I am out of academics. So by attending these things, I myself learn a lot. Thank you very much. Thank you.
Thank you. Thank you, sir. So, Naveen sir, would you like to add something?
I think it's time to invite Tanveer for vote of thanks.
Thanks. So, on behalf of the organizing team, it is my privilege to deliver the vote of thanks for today's very enriching session of paper presentations of RSACP, RSA Youth Conclave 2025 by our young, talented anesthesia residents and senior residents. So, first and foremost, a big congratulations to all the presenters. Your dedication, clarity of thought, and scientific curiosity were truly impressive. A special word of gratitude to our judges, Dr. Parul Jindal ma'am, Dr. Swati Chabda, Dr. Nishan Sahai, who brought in their expertise and thoughtful evaluation, helping guide and encourage these young minds with fairness and insight. My sincere thanks to my co-coordinators, Dr. Neha Sinha, Dr. Nitin Chaudhary, and Dr. Neha Sharma, who worked tirelessly for the success of today's webinar. I extend my sincere thanks to our patron RSA, Dr. Tej K. Kaul sir, our president, Dr. Naveen Lotra sir, our secretary, Dr. Vishal Singla sir, for their continued encouragement and support. Your vision and guidance made this platform for young anesthesiologists possible, and we are deeply grateful for the opportunity. Thank you each and everyone who joined us today. Your presence and encouragement added great value to this event. Let's continue to support and uplift the next generation of our society. Thank you one and all. Long live RSA.
Long live RSA.
Long live RSA,
Long
and
live.
see you for the session 2, which will be announced along with the winners. Good night. Take care. God bless.
Good
Good night,
night.
everyone.
Good night.
Good night, sir. Good night, everyone.
Bye.